Good morning, everyone. I'm Michael McNutt, Director of Education and Events with Wedi, and it's my pleasure to welcome you to our virtual spotlight on value-based care, sponsored by InterSystems. It's my pleasure to introduce Wedi's Vice President of Federal Affairs, Rob Tennant.
Thank you, Michael, and let me add my welcome. This is a very important topic. I know that you're going to find a lot of great information from our phenomenal lineup of speakers. So, but before we jump into that, I just wanted to give you an overview of Wedi in case you don't know too much about us. We were formed way back in the first Bush administration. The then Secretary of Health and Human Services, Dr. Lewis Sullivan, as a practicing physician, knew firsthand the challenges that providers and payers faced exchanging health data. So he actually brought in the leaders in healthcare and said, you need to fix this. And so that led to the creation of the Working Group for Electronic Data Interchange. And these folks created some very groundbreaking reports that were later folded into the legislation that we all know as HIPAA. And in HIPAA, Wedi was named as an advisor to HHS, and we continue to perform that role. In fact, we have very close relationships with the Office for Civil Rights, the Office of the National Coordinator for Health IT, and with the Centers for Medicare and Medicaid Services. Both ONC and CMS serve on the Wedi Board of Directors. Next slide, please. So how do we affect change? Well, we really act as a convener and drive consensus in healthcare, which is not always an easy thing to do. We have now more than 250 member organizations. We work in various ways. We have work groups and sub-work groups and task groups, and I'll talk about those in a little bit. But we also have open public forums. We have conferences and virtual spotlights like the one you're attending today. And we have policy advisory groups. So the work that we do entails tracking regulations, developing thought pieces and recommendations to our work groups. We have listservs that we're able to exchange data and thought pieces between. And we have, of course, conferences, forums, and webinars. In particular, we're very focused on our role as advisor to HHS. And so we provide testimony to groups like the National Committee on Violent Health Statistics, and we submit many comment letters to the government on various regulations and requests for information. And then we have a lot of special initiatives as things come up in healthcare. Back one slide. So, sorry, Michael. I just want to let you know we have a very diverse membership. We have practitioners in hospitals. We have health plans and state organizations, labs. Of course, we have government agencies, various types of vendors, including clearinghouses, standards organizations, and other interested stakeholders as well. And so I wanted to talk about, on the next slide, some of our work groups and sub-work groups and our task groups. This is where a lot of the Wedi work gets done. So you can see here, we have a lot of different work groups. We have privacy and security, data exchange, remittance, advice and payments, claims, attachments, property and casualty, eligibility and benefits, prior authorization, just like you were hearing from one of the co-chairs, Heather Thomas from the AMA, and others. And we have two fairly new groups. One is the Administrative Automation Task Group, which is very much focused on trying to identify ways to automate manual processes that slow the industry down. And we also have a task group specific to the No Surprises Act, in particular, the data exchange requirements contained in that legislation. And so if these are of interest to you or your colleagues, I encourage you to visit our Workgroup community homepage to learn more about this and, of course, to sign up. The nice thing about being a Wedi member is that every one of your organization's staff are also a Wedi member. So you may have somebody who is an expert in privacy and security. They may want to join our privacy and security work group, or they may have more specific interest in some of the transactions. So next slide, please. So overall, again, I see Wedi, I've been involved with Wedi for more than 20 years. It's a wonderful platform for bringing the various and diverse groups in healthcare together to identify challenges and, most importantly, come up with solutions. So we convene, we provide guidance, we provide, again, an opportunity to share opinions and views. And I would certainly encourage you, if you're interested in becoming a Wedi member, go to wedi.org and learn more. And with that, it's really my pleasure to introduce Michael Patwell. Michael is Principal Consultant, Value-Based Care for Edifecs, but most importantly, he is a new member of the Wedi family, and he has graciously agreed to take on the role as chair of the Wedi Payment Models Work Group. So with that, I'll turn it over to Michael.
Thank you very much, Robert. The introduction's already done, but again, my name is Mike Patwell. I am a principal consultant of value-based care at Edifecs. I've also been a member of the Payment Models Work Group for a number of years, and I'm very proud to be the current chair. A little bit about the work group. The Payment Models Work Group is chartered with exploring new and existing value-based payment models. Our mission is to be a source of both educational and advisory information in order to break down the complexities across all payment models. We produce informational white papers, educational webinars, and industry surveys in addition to a number of other artifacts. With the newer and more complex value-based payment models that are emerging today, we will be ramping up more on the advisory work products to assist our Wedi membership in succeeding in the adoption and implementation of these models. If you would like to join our work group, you can visit the Wedi work group community homepage to learn more and sign up, or just reach out via email to Samantha Holby. So as you can see, we have quite the impressive set of 7 sessions and even more impressive roster of speakers. We'll be having a 30-minute break midway through, so everybody can take care of a few things, grab a bite to eat, and be ready for our second half. Just a couple of housekeeping items before we get started. If you have a question for us during the presentations, please use the chat feature on the Zoom control bar. We will have a team of folks monitoring and get as many questions in as possible. All slides and recordings will be emailed shortly after the virtual spotlight. And before we get started, Wedi, our CEO and President Charles Stellar, along with our entire board of directors, would like to thank InterSystems for sponsoring this virtual spotlight. InterSystems provides next generation solutions for multiple industries, including healthcare. Their cloud-first platforms solve complex programs across the globe, including interoperability, performance, and scalability. Since 1978, InterSystems has been delivering award-winning 24/7 support in more than 80 countries. They are privately held and headquartered in Cambridge, Massachusetts. For more information, please visit intersystems.com. Back to you, Robert.
Thank you, Michael. And it's my pleasure to introduce our first speaker, former colleague and friend of mine, Mollie Gelburd. Mollie is Senior Director of Delivery System and Payment Transformation at America's Health Insurance Plans based in Washington, D.C. AHIP is the National Association representing organizations that provide coverage for healthcare and related services. At AHIP, Mollie is responsible for assessing market trends, educating members, developing policy, and responding to regulatory and legislative proposals in the areas of innovation in healthcare delivery and payment models and fee-for-service payments to providers. Previously, Mollie worked at the Medical Group Management Association as an associate director, where she worked on an array of healthcare issues, including alternative payment models, quality reporting, Medicare physician payment, and fraud and abuse regulations. Mollie is a phenomenal resource. She knows everything about alternative payment models, both from the provider and the payer side now. So Mollie, thank you so much for joining us today.
Thank you, Rob. I'm going to go ahead and share my screen now. Yes, Rob and I worked together at MGMA, and in fact, he was such a great colleague that I left about 2 months after he did. I just couldn't stand to work at MGMA without Rob. So it's always good to see him. So hopefully you all can see my slides now. And thanks so much to Rob for the introduction. I've been at AHIP about a year and a half now. And so it's been very interesting and great to see how payment models work on both the provider side and then now on the payer side. So as Rob mentioned, AHIP is the national association that represents health insurance providers, and that ranges from large national plans to small regional plans, integrated delivery networks, and so forth. So I'll start by talking a little bit about some national trends in value-based payment in the health insurance provider market. So AHIP members are committed to value-based care, and I hope that my presentation today will provide some insights into the type of work that plans are doing to implement these models and to improve quality and affordability for patients and partner with providers, vendors, and other stakeholders in this mission. And I think that value-based care is truly an area where interests align, but it is also an area where it's going to take some work to get past some of the growing pains that are associated with such a significant shift in payment and delivery reform. So I think we're still in that stage where we're trying to figure it all out and test different models and then make refinements based on what we learn. And I'll start by saying, I think that value-based care can mean a lot of different things. Value-based payment describes a variety of different models, but the overarching goal of these arrangements is to pay for value or better patient outcomes rather than volume, such as payment for each service. So value-based care, I think of as being the end goal of value-based payment. It's what payment is trying to incentivize by having economic incentives that change the way care is delivered. So I think often we use terms interchangeably, but I really think of payment, value-based payment, as being a mechanism or tool to getting to value-based care. So one of the leading national stakeholders that's driving these changes is the Healthcare Payment Learning and Action Network, or LAN. And I thought this would be a logical place to start talking about what health insurance providers are doing, because the LAN is a partnership between HHS and several private entities or stakeholders. So AHIP partners with the LAN on its APM or alternative payment model measurement survey each year. So the LAN, in addition to measuring adoption of value-based payment models, also convenes stakeholders to discuss trends and best practices via work groups or other public-facing events. And importantly, it also endeavors to standardize terminology around APMs and to create a framework of consistent terms that can be used across stakeholders, across the healthcare system, really. So you've likely seen this framework before if you've been around value-based payment for a while. And this outlines APMs by category. So that ranges from traditional fee-for-service, which is category 1, to category 2, which is pay for performance, which is like Medicare's MIPS program. And then it moves up to category 3, which is shared savings. And then finally, category 4 is the most advanced type of models, which is population-based. So as part of the LAN's effort, it measures APM adoption, as I mentioned, and it focuses on these 2 categories, on categories 3 and 4. It does not include category 2 in its measurement data. So in December 2021, the LAN released results from the 2020 measurement year, which is, they share not only the aggregate results across all the payers that report data, but also they break it down by line of business. And this is where AHIP partners with the LAN by recruiting member plans to participate and gathering that data and then providing it to the LAN to include along with the other lines of business. So the robustness of the data that the LAN gathers is really impressive. In 2020, the data that was gathered covered 80% of lives. So this is a pretty significant undertaking and is quite comprehensive. So you can see here that that APM adoption was still relatively high relative to past years in 2020, even despite the COVID pandemic in 2020. So Medicare Advantage plans had the highest rate of APM adoption at 58%, followed by traditional Medicare at 42%, commercial plans at 35.5%, and Medicaid just behind at 34.4%. And you can see in these little call outs that are colored, that indicates the models that have downside risk. So category 3 is essentially bifurcated into shared savings only, which doesn't entail any formal financial downside risk. And category 3B, which is a shared savings model that also entails shared losses. So these little call outs show the models that have downside risk, which are generally considered to be more advanced by some at least. So looking at the data over time, I thought this was interesting to see some of the trends in terms of adoption of these models. So you can see that, and hopefully you can see this little key, but the blue is the aggregate data, green is commercial, blue is Medicaid, red is Medicare Advantage, and yellow is Medicare fee-for-service. So you can see that Medicare Advantage has had the highest rate of APM adoption since the LAN was reporting out data by line of business. And then you can also see how Medicaid has made a lot of progress in recent years in increasing APM adoption, going from 23% in 2018 up to 35% in 2020. And so that's a result of a lot of very interesting initiatives that are going on in the states in Medicaid programs, which health plans will often partner with Medicaid for their Medicaid managed care plans and adopt the same model or similar models. So in addition to looking at quantitative data about APM adoption, the LAN also includes some qualitative questions about the future and also design of APMs. So in 2020, 87% of payers reported that they believe APM adoption will continue to increase. And 75% of plans reported leveraging payment models to reduce disparities, which is a number that's increasing over time. APMs can be a great opportunity to drive the type of changes and patient-centered activities that we want to see. So one of those is to try to reduce disparities, and it's exciting to see that plans are using these models to try to accomplish that. So over the next few slides, I'll go over some specific models that plans are implementing, and I'll note a few trends up front. So some payers will implement APMs on a broad scale, such as a national model like Medicare does with its Medicare Shared Savings Program, by making the models available to all contracted providers across the country. But in other instances, the plan will pilot a model with one contracted entity, such as one hospital system. And then in other cases, you'll have models that are available in a region. Of course, for plans that are only operating in a specific state, that might be models that are statewide, or again, just one or two contracted entities. Plans also, like I said, partner with Medicaid and also Medicare. So Medicare's Innovation Center that pilot tests models for Medicare beneficiaries will sometimes open up models for payer alignment and participation as well. So plans can participate alongside of Medicare, which streamlines and aligns requirements, but they can also pilot their own arrangements. And I'll note that AHIP and our members are also very supportive of alignment across payers where possible and where it makes sense, because this can reduce provider burden, it can increase buy-in, it can have, it's easier to evaluate. But part of the problem in the private payer market is that it's hard to collaborate across payers due to antitrust regulations. So, for example, payers face very stringent rules when it comes to cross-payer collaboration on specific payment matters, because it could be seen as collusion, even when you're trying to do something laudable like align programs. So one of the ways that plans can innovate with one another is through CMMI demonstrations. So even though those are ordinarily designed with Medicare beneficiaries in mind, when CMMI invites payers to participate, then that can create some waiver protection to be able to collaborate without concern about every single regulatory barrier that exists without that protection. So that was something that I learned coming to AHIP, just that it can be hard to come to consensus and alignment due to the regulatory environment. So Blue Cross Blue Shield of North Carolina has implemented numerous value-based payment arrangements, but the one I chose to talk about today is called the Blue Premier model. And this operates similar to an accountable care organization, or ACO, and is geared toward primary care providers. The plan provides numerous supports for practices that choose to participate, such as technology and data analytics to help provide insights into patient experience and gaps of care, and also a more comprehensive picture of the patient. If they're going out of network for care, they can help show where that care was received and what happened. Blue Cross of North Carolina partners with Allidaid, which you might be familiar with, to help independent practices get off the ground with supports. And the results have been positive from this model. In 2020, the Blue Premier program generated an estimated $197 million in cost savings, which follows $153 million in cost savings from 2019. Some other key improvements or metrics besides cost savings include a 15% reduction in unplanned hospital readmission rates among adults compared to 2019. And then there were some modest increases in the use of screening tools. So that was up from 51% in 2019 to 53% in 2020. Again, modest, but still positive to see that trend. And then also more colorectal screenings. And of course, the hopes in increasing screenings is to improve long-term quality and cost savings goals. So the next model I wanted to mention is from Capital District Physicians Health Plan, which is a plan that operates in and around New York. And this plan implemented an enhanced primary care program in 2011 that uses a capitated model, which pays physicians a fixed rate for attributed patients per month. And flexible payment designs like this can enable physicians and other providers to furnish care that might not be traditionally reimbursed, like care coordination or care management, chronic disease management, and that sort of thing. So while payers are starting to pay for these types of activities, like the chronic care management code that Medicare adopted, sometimes the billing requirements and restrictions for these can make it difficult to actually get paid for these services. But in a flexible payment arrangement like capitation, there's less reliance on the actual code that's being billed, as a global payment allows providers to choose what care is most appropriate for the patient without being tethered to a set of individual codes. So Capital Physicians offers its participants access to a risk-adjusted predictive modeling tool that's called Medical Intelligence. And it shares feedback and insights on quality and utilization data. The plan also has a physician engagement team that helps primary care providers with insights and support around specialty care. And results from this model have also been promising, achieving cost savings and higher quality outcomes comparative to practices outside the program. And this model has actually been cited in a few state efforts, like state collaboratives that bring stakeholders together with the Department of Insurance or Department of Health to look into models that they want to promote. So this has really been a successful and interesting model to observe and learn about. So in terms of specialty models, we're starting to see more models in the private health insurance provider market that focus on maternal health. And this particularly lends itself to a bundled payment. However, there's lots of different ways that you could structure payment for maternal care. But a bundled payment can work well for care that is around an episode, such as a pregnancy. So some payers are implementing bundles for an entire perinatal period, which might begin at the discovery of pregnancy, cover the labor and delivery, and then also a certain amount of days postpartum or post-delivery. Some models will include newborn care as well. And then increasingly, we're seeing more focus on including patients that have high-risk pregnancies. So at first, as models are getting off the ground, it seemed, my dog might start barking, so I apologize. We'll see models that are new or in their infancy exclude higher risk patients, but then once they get off the ground, they'll start expanding that so that other patients can benefit from these models. So as an example, Horizon Blue Cross Blue Shield of New Jersey implemented an episodic model for pregnancy care starting in 2013 with just 2 practices in New Jersey, but has expanded it since then to over 300 practices statewide. And this is an upside only model, so practices are not responsible for paying back losses if they are incurred. And it's a global budget that is calculated based on 2 years of the practice's own historical data. and the budget remains the same regardless of whether delivery is vaginal or via cesarean section, to encourage, or rather to discourage elective cesarean sections that are not necessary. The bundle also includes professional fees, facility fees that are incurred at the hospital, and any ancillary services. And Horizon reports a 32% reduction in the number of cesarean births among patients that are treated by providers that participate in this model comparative to non-participants. So another primary care model is Highmark's True Performance value-based reimbursement program. And this helps to ensure that providers are meeting nationally recognized evidence-based quality measures, such as giving recommended immunizations, appropriate drug therapy, cancer screenings, and annual wellness exams. Practices can receive additional funds for managing attributed patients and are rewarded for performance on quality and cost utilization metrics. And there's also an available bonus metric or bonus payment for care coordination activities. So results from this model showed that the primary care doctors that participate in this achieved nearly $2 billion in total cost savings since 2017. More recent results since in 2020 showed that Highmark members that were seeing primary care doctors in this program had lower emergency department utilization than those not in the program, and potentially avoided costs of $66 million. There were also lower inpatient admissions from providers that were in this program, or rather for patients that sought care from providers in this program comparative to patients outside of the model. So these are just a few of the examples of different payment arrangements that plans are doing. As I mentioned, there's sometimes these will be implemented locally or on a small scale, and then either the model will grow or be refined and grow, or they're models that are implemented more broadly, like in several states or with several different providers. So I wanted to talk a little bit about some of the activities or like new features, I guess, of value-based models. So as I mentioned, payers will use these models as tools to incentivize activities that promote better health or better patient experiences, like coordinating care across the patient's care team, or increasing screenings, or addressing social determinants of health. So it's becoming more apparent that a person's health is influenced by many factors outside of just healthcare alone. And other factors might be defined by the conditions and environment that people are born in, where they grow, where they live, where they work, and can include financial, social, family, and education aspects. So social barriers to health can result in poorer health status, health disparities, and also a less positive patient experience, and also increased costs for both patients and the system more broadly. So AHIP has endeavored to focus on this, and addressing social determinants of health and reducing disparities has been one of our top priorities, and also a long-term strategic priority. So AHIP launched an initiative called Project Link in 2019, which is a learning collaborative for our members to share innovative programs, learn from each other, and work together to address health barriers that are created by social determinants of health. So now I'll move on to the last section that I prepared, and that's on some recommendations that we have for how to improve models and the value-based environment moving forward. So I talked a little bit about multi-payer alignment at the beginning, but the benefit of having alignment across payers around model design is that it streamlines performance and administrative workflows for providers. Because value-based payment requires new care processes and changes, having consistency across payers and contracts can help with provider buy-in, reduce burden, and can also aid success. So currently, multi-payer models have been largely developed and implemented by CMI, Medicare's Innovation Center. And part of our recommendations is to have CMI leverage the capabilities of payers more and use and leverage their experience and the work they've done to develop models by involving payers at the outset of model design, rather than just inviting them kind of as an afterthought. And so through this, we've had some great opportunity to work with CMMI on feedback and that sort of thing with models that it's developing. And so as I mentioned, sometimes CMMI will implement multi-payer models like the enhancing oncology care model that was just announced last month, I think. That's a multi-payer model. And so that can, as I said, streamline things for providers that want to participate because they can treat patients in a payer agnostic way. They don't have to worry about, achieving quality measures that are required from one payer for one patient. Everything is just streamlined. And then there are certain attributes that you can work for with alignment. Not every payer is going to have the same patient population. Of course, Medicare is different from, it's a different, a unique patient population. So there might be things that would need to be a little bit different, depending on that. But there are common elements where, you can have alignment and then that can help contribute to success. So some of that might be around data sharing, like having common dashboard elements or common exchange standards for population health files. And then within the payment model itself, something like attribution, how patients are aligned to a provider can have consistency there. We talked about health equity earlier, but advancing health equity is another area where we've developed some recommendations. So this includes recommending to HHS to work with industry stakeholders and across agencies to develop and incorporate appropriate social determinant of health programs, including reporting and metrics for model participants. This also includes working across the public and private sector to identify best practices, and then best practices being around how to best advance health equity and minimize social determinants of health. So this might include collecting standardized data, measure segmentation, staff training, and diversity. We've also been exploring ways to incorporate social determinants of health into risk adjustment methodologies. And I've been working on looking into this more closely. For quality measurement, again, seeking greater alignment of public and private quality measures and reporting. And then also encouraging CMS to work with the Core Quality Measure Collaborative, CQMC, to guide its work and define and track progress on core clinical measures, and also supporting CMS's goal to increase the use of patient-reported outcomes measures in order to empower patients and elevate their voice. I think this is the last one. Oh no, I have another one. And then lastly, developing models for specialists. There's been a fair amount of innovation in the primary care space, which is great. As primary care is the quarterback of the health system, but one area where we are encouraging more progress is in specialty models and developing multi-payer models for specialists would be a recommendation that we have for CMS. And then also we have some specific recommendations on specialty specific models. The hospital at home program that Medicare implemented through waivers has been really interesting to watch, but payers can have a hard time scaling or piloting their own without support, or they have to develop their own metrics and models without having something that they can align to. So one way that we could make hospital at home programs more sustainable long-term could be to have a multi-payer demonstration. Encouraging home dialysis or access to modality of choice for patients with chronic kidney disease like ESRD. So CMS does already have some models that encourage this through their payment incentives, but again, allowing insurance plans to partner alongside. So those conclude my recommendations, and I'll make sure to send these slides out, but we have produced 2 issue briefs that further highlight some of the work that plans are doing in value-based payment. One is on maternal health and value-based models, and then the next is integrating behavioral health into primary care. And so that talks about some other work that can be done to integrate behavioral health, but also discusses value-based payment. Okay, so I'm looking at the questions. Okay, can you point me to some information on the work being done to incorporate social determinants of health into risk adjustment? Yes, I would be glad to send some of what we've developed. We have a really excellent person on our staff that does this work, and I can coordinate with her to make sure that I get some good up-to-date information, and I'll send that along with my slides. Okay, health equity requiring social determinant of health data is tough. CMS has recently warned that their data can be very inaccurate in some cases. Is AHIP talking to CMS about payers sending their data to CMS to be shared for multi-payer models to share and succeed? That's a good question. I know that we do dialogue frequently with them about this, and that's something that I can bring up with our staffer that handles this issue more closely than me. But we have so many different initiatives and work groups and work that's going on in this that I imagine that is something that has come up before, but I'd have to get some more information.
And Mollie, first of all, thank you very much. Great information. I do have a few questions, if you don't mind. With the Wedi audience, we're very focused on data exchange. And when you think about how we can make these APMs successful, a lot of it depends on information flow from the provider to the payer, from the payer back to the provider. Can you comment a little bit about how these models use data, not just SDOH, but you referenced ADT, the admit, discharge, transfer. And that's so important, especially for the primary care doc, to know that their diabetic patient landed in the ER on the weekend, to be able to follow up and make sure they're adhering to their medications. I don't know if you can comment a little bit on that.
Yeah, sure. So what I'll hear about is when like payers will partner with a vendor or a third party to help kind of marry the data sometimes, or to exchange it when it's not easily done via the existing systems. And so that might include, contracting with somebody else to try to overcome some of the barriers that exist due to, the inoperable systems, but coming over to the payer side, I've learned that payers actually face some of the same problems as providers do in terms of systems that don't talk to each other, and having EMRs that can't exchange information, or the data fields aren't the same, and so it doesn't integrate. So they face the same problems with that sort of stuff, and EMRs are just one example. But then there's we have some members that have also been doing work to try to pass bills to create health information exchanges and that sort of thing. So there's barriers on the plan side as well, when it comes to data sharing, and it's just trying to come up with solutions that work for everybody. But yeah, I certainly recognize the limitations with data sharing, and there's so many different ways that data flow and so many different types of data that's important to help inform decisions.
Yeah, and there is some hope that the Trusted Exchange Framework and Common Agreement that ONC has been working on will help in that respect. We've talked a little bit about risk adjustment, and I've never met a physician in a APM who didn't argue that their patients were sicker than others. How can plans and providers sort of work together to make sure patient and cost attribution and risk adjustment is fully worked into these models, and so they're fair on both sides?
Yeah, I think it's coming up with a sound methodology to do it, and then making sure that you're getting the full picture of a patient. And that's where I think even though risk adjustment has been around, it's we're now talking about incorporating non-health factors like the social determinants into risk adjustment. So it's something that is evolving as we learn more, and then working together with providers to try to develop those methodologies to make sure that they're accurate, and then they can adequately adjust payments. But it's complex, and it's something I think that has been refined a lot, and we're still working on what the best methods are, and what the best practices are. But that's why I think it's so important to have conversations with kind of across the system, to help us all understand and all be able to contribute to that, since there's no one person or one entity that's going to have the answer.
Gotcha. Rita has asked a question. Can you discuss more how SDOH measures were developed, specifically perspectives informing development, if they included community, patient, client voices?
That's a really good question. So the measures and that work is still ongoing. We have a work group that specifically works on this, and I'd have to get an update from the chairs of the work group about what their progress is. But I know that they've been meeting monthly or periodically to discuss this, and to come up with measures and recommendations. So I know they talk a lot about leveraging the voice of community-based organizations. So I do think that they're looking at kind of the full picture of players, but I'd have to go back to them to get some more information to be able to provide details.
Gotcha. And Mollie, you mentioned a lot about sort of multi-payer alignment, and from the provider side, especially if they're participating in multiple APMs, aligning some of the measures and aligning some of the data collection requirements obviously would reduce the burden. Can you talk a little bit more about how AHIP is promoting this concept of sort of multi-payer alignment?
Yeah, sure. So, as I mentioned, it's easiest to do this when we have CMMI convening because it, like I said, it can offer some regulatory protection, because, you know, it's obviously antitrust rules are well intended, but then it makes it hard for payers to come together to then actually align with one another. So that's where CMI is helpful in kind of, you know, if they're in the room, then it's like, well, it creates this not a formal waiver, but it essentially blesses the conversation. So it's involved a lot of discussion with CMMI about how we can help them and leverage some of the work that payers have done to help inform CMMI models and you know, to, I guess, just leverage what we've done already that we can then give them, and then have you know, have them incorporate that, and then you already have plan buy-in then if you have the multi-payer because they've helped create it. So it's having conversations with CMMI, it's working with the provider community on what they want to see aligned, because alignment doesn't, you know, I think it's one way to help improve models and make them successful, but, you know, it has to be a good model for alignment to make sense. You know, if you're all aligned on a model that doesn't work, or providers don't like, or patient, it's not improving outcomes, then that's not good. So it's also making sure that the fundamental building blocks of the model are appropriate. So it's, and this is all kind of happening at the same time. You know, it's like, as we develop the best practices, we want it to also be aligned, but you don't want to create alignment if something is still, you know, untested or unknown, in case it needs to be refined.
And Michael, do you want to ask your question?
Sure, thank you. Mollie, I was recently at the Blues National Summit, and I was asked more than once about Z codes, you know, the possibility of Z codes being submitted by providers at the point of service would allow payers and CMS and even state Medicaids to collect recent and accurate social determinants of data. Is AHIP talking to their membership about requiring Z codes to be submitted with claims?
Yes. So actually, this is something that we just we're talking about recently. In the Medicare inpatient rule that came out, the proposed rule for fiscal year 2023, they had put out an RFI around whether or not Z code should be required on claim forms. And so we just had this conversation recently, and you know, we support that concept, and have done a lot of work on improving and developing the Z codes themselves. But before it goes live, and if Medicare were to move forward with that, or if plans were then to mirror that and adopt that, there'd need to be a lot of education around how to do that first. So, you know, while supportive of that concept, we just want to see it done right and make sure that there's education, and then also some of the concerns that we heard was about the limitation of diagnoses on the claim form as it exists now. And I know this is a Rob Tennant favorite, is about overwhelming the claim form, and, you know, just fitting things in boxes where there's space if there's not space where it's supposed to go. So I think the limit might be 25 now, codes. And so to allow accurate and robust reporting, that might be something that would need to be changed. So again, it's just making sure that all that is kind of set up right for the policy to succeed. But yeah, the Z codes are definitely something that you know, we've done work on and have submitted a lot of comments and had conversations with CDC and CMS on how to improve those, and then also make sure that the language that's used in them is inclusive and that's accurate.
Thank you.
And I have a question. Oh, yes.
Well, go ahead.
Okay, I have a question in the chat. What role will state Medicaid agencies themselves have in administering payment models for their managed care or fee-for-service population in the short or midterm? do you think it will be much different compared to how state Medicaids operate today? So, you know, I'm newer to the Medicaid space, but what I've noticed is that it seems like in the past 5 or so years, there's been a lot more effort to have these like convening sessions of state Medicaid agencies where they bring payers and providers to the table to talk about payment models, and then to come up with a good model that they then kind of want to bless and then implement for Medicaid, and then either require their managed care plans to participate or encourage or offer. And it really seems to range, you know, where some will require managed care plans to participate in those models, others will just make it available as an option. So that seems to be increasing, at least in my experience. And then in terms of whether that will be different to how they operate today, I think they're just continuing to make progress in this. And sometimes I'll notice there might be a particular state that might not have an APM yet, but then they'll have something in the state legislature that will have a mandate to have that start having the conversations around it. So I think it definitely seems to be trending toward you know, having more models. And then also you'll see that there might be a focus on a particular specialty like maternal or behavioral health. And so then they'll really rally around that as like a first rollout of what they're doing.
Excellent. Well, Mollie, let me just say thank you for sharing your expertise with the Wedi audience. It was a wonderful presentation. And thanks for addressing all the questions as well. And with that, Michael, I'll turn it over to you to introduce our next session.
Thank you so much for having me.
Thank you, Mollie.
And thank you, Robert. So our next session will be led by our sponsor, InterSystems. Both Linda Rowe and Mark Munt will be presenting Turning Data into Action to Support Value-Based Care. Over to you, Linda and Mark.
Perfect. Thank you to the entire Wedi team. We're really excited to be here. We're relatively new members of Wedi. We joined back in December, but I want to thank everyone. It's been a very positive, welcoming experience to be part of Wedi. So thanks to everyone. So before I get into the sort of nuts and bolts, I just want to introduce who we are, what we do, before Mark and I jump in and start talking about how we help our customers support value-based care. And I think it's interesting, a lot of the, you know, Mollie's slides and a lot of the discussion that people are having, we can sort of show some of the data sharing and richness of how using data and information can help with value-based care. So first of all, InterSystems has been around for over 40 years. We're based in Cambridge, Massachusetts. We started our journey through a database platform and technology that enabled our, what we call application partners, to actually build and develop their software that they sold to the market. And probably the most prominent one that you would know is Epic, has been built on our technology, but others such as GE and 3M and LabCorp and Quest, and sort of the list goes on. There are hundreds of technology partners out there that build their applications. We then used our own technology to build our flagship product, which is called HealthShare. HealthShare is our interoperability product that allows us to bring in disparate data from all types of sources, to aggregate that, deduplicate that, and create sort of a clean set of data in a longitudinal member-centric or patient-centric form, depending on whether you are in our payer market or provider. So we do sell into both payers, providers, life sciences, and as well as health information exchanges. And those use our product in some similar ways and some different ways. So with that, if you could go to the next slide, I'm going to tee up our demo.
All right, Linda, I'm just going to do take over sharing now.
Okay. There we
We're
go.
good to go.
All right. So first slide, Mark. So the first thing I want to talk about is the fact that it's really hard to do anything without good, clean data. We think about, the data management, the data that all of you use day in and day out to manage your organizations, your business, your interactions with patients. But often, as we have heard, the data that we get is not always the data we expect. So go to the next slide, please, Mark. I find it very interesting. We do a lot of work with Gartner, and Mandy Bishop, who is their lead analyst for the payer market, did this piece multiple times. She's written about it, but it's called the Clinical Data Integration Value Chain. And I think it's really important because the point here is that it starts with payers and providers having a data use agreement in place, but then going through this whole process. So acquiring the data, standardizing it. So, syntactic and semantic interoperability, and sort of making sure that the data you actually get is data that is usable and harmonized. That then gets brought into sort of a clinical data repository. In our case, we call it Unified Care Record, where you integrate and deploy that, but you go through this whole sort of prepare, reconcile, manage process before you deploy it. And then once it's sort of been cleaned up, it's then applicable and can be, I always talk about acquire once, use many. You can then use it for all these things that we've just talked about, for risk adjustment, for quality measure improvement, for like prior authorization, care coordination, and some other advanced analytics. So we really appreciate this model because it's something that we have stressed and implemented over our history. So if you go to the next slide. So basically here is our version of it. So again, we do the same process. We acquire the data, we validate it. So we actually have Enterprise Master Patient Index, or EMPI, to do the patient matching. We do terminology normalization and data enrichment, and then we'll unify that data, right? We'll consolidate it into a single, what we call unified care record. We do deduplicate records, and a lot of people don't understand the value of that, where you may be getting a lab value from your provider network, but you're also getting a lab value from the lab vendor. And if you don't deduplicate that, then you'll be double counting, or you may be looking at duplicate information. And then again, we can share that data in many formats to external sources. We can do it with APIs, we can do it with flat files, we can use it with other standards like X12 or HL7. But the point is, we take that data, that clean data, and then we apply it to these various use cases. Next slide, please, Mark. So we're going to talk about 3 use cases. So the first one we're going to talk about is quality measures and how we use that data to really help look at both gaps in care as well as looking at what we call performance measurement. So we don't function as a quality measure submitter, but we do enable providers and payers to sort of work together to track and trend over time what is happening with their cohorts of diabetics, CHF patients, to figure out do they need intervention. And there was a question in the previous session about using ADTs, and I would say one of the top use cases we see across our entire both payer and provider market is the use of alerts and notifications to allow others to know when a patient or member has, sought care in an emergency room, has transitioned and been admitted as an inpatient, has transitioned and been discharged or sent to post-acute care. So all those are really important use cases. So we'll talk about quality measures. Then we're going to talk a little bit about risk adjustment, and then we're going to talk about some great work that we have been doing through the Da Vinci project with prior auth. So I know we don't have a lot of time, so let's get rolling here, Mark. So I think one of the things is that there are so many approaches to quality reporting right now, but it all requires data. So there's sort of the hybrid measures that we're going to be talking about that require the clinical data. And there's the traditional access to the chart. I call it the chart chase, the ability to have a third-party vendor help payers get access to that data. There's non-standard supplemental data. So that's data that you'll bring in from external sources that has not gone through a validation process with NCQA or a certifier. And then there's standard supplemental data. And many of you may be familiar with the new NCQA, or not so new anymore, DAB program that actually can help payers get standard supplemental data from their HIE partners. There's new ECDS reporting, again, electronic clinical data systems. And again, that's taking data from multiple sources, EHRs, HIEs, registries, case managements, and using CQL to define the measure specification. Still needs to be submitted through a submission process, a vendor that's been certified by NCQA. But I think my point is that we're really moving towards more clinically based, high measures, more using of interoperability technology and FHIR and CQL to define those measures, which ultimately will hopefully help both providers and payers streamline how that data moves through that data pipeline. So next slide, please. And again, this is just a visual of sort of how our platform enables this. So I'm not going to dwell on this, and we'll provide slides. But the point is that, the NCQA data aggregator program has really been important for our HIE customers. A number of them have gone through the process, and we are going to be going through the process as a data supporter of a DAB program. But I'd rather move on, but this is sort of how we use that data and turn it into the data that a certified HEDIS submission vendor can use. Next slide, Mark. So I am not going to spend a lot of time on this slide because Mark's actually going to show you how this all works. But I think this is a really interesting sort of way to use the data. So if you look at that top purple line, that's your total population that you're looking at. And the denominator here are our diabetics that we have defined as a population. But then as you look over time, there are a couple things you want to look at. The first is you want to look at those that are out of control, those whose A1C has gone over 9, right? You want to know sort of out of control. But even more importantly, you want to know who are your gaps in care. And this is showing both on the same chart. It shows you those that have not had, who are in that denominator, but haven't had that visit, haven't had that A1C draw done, in the look back period, 12 or 18 months. So what Mark is going to do is he's going to bring it up and show you sort of interactively how this works using, again, clinical data to drive it.
And I hope everyone can see my screen here. I've switched over from the presentation. And so, yeah, as Linda was mentioning, it's really about marshaling the data that payers already have available to them from a variety of sources. So the data that we're looking at here has come in from different EMRs, it's come in from claims, from different provider organizations, and we've normalized it so we can line it up and use it for trending. And so we don't miss, we don't inaccurately say there's a gap in care just because we didn't consider data from one of their ambulatory providers or something like that. So as Linda mentioned, we can see here at the top, we're looking at the total population, and we're looking at this, how it changes over time. We're able to do trending here. And the other important point I think to note is that this isn't just about reporting your quality measures. It's also about being able to see your progress and your performance at the current point in time, so you can intervene early enough to make an actual difference in your results. So we can take a look at these things. These bar charts, like Linda mentioned, are broken down into the portion of the population that doesn't have a current HbA1c result. And then the portion of that population that has a current result, but it's out of range, and so they're considered uncontrolled. So just as an example, we can click through and we can see, the actual members of that population. I'll call out my favorite test patient here, Brooke Bladen, who you can see as of March has not had an HbA1c test in the look back period. And then by April, Brooke Bladen has had that, and it was out of range. It's 10.10. So she's been moved into this uncontrolled group. And then because we have, in the solution, we have access to the full longitudinal patient record for all of the people in the cohort, we can click through, and this is just a very simple rendering of the of this patient's complete medical record. But we can also could also click through into our interactive clinical viewer, which gives an EMR-like view of the longitudinal patient record. So Linda, back to you.
Yep. All right. So thanks, Mark. Let's move on to risk adjustment. So I'm going to actually skip the first slide because I think people are familiar with, risk adjustment. But, overall, the goal is to, document capture HCCs to make sure that every year that we've got an appropriate accounting of the clinical acuity of the membership / patients attributed to a particular panel. And so you may know that last year, Linda Rowe was a diabetic, but you also have to have an encounter this year that shows that Linda Rowe is a diabetic. So, we think that there's a lot of value in having this clinical data to be able to assist in risk adjustment. So if you go to the next slide, please. So again, if you think about some of the, use cases, and again, Mark's going to show a very quick dashboard about this, but, there's the, I don't have a diagnosis, right, at all. So for some reason, I can't find a diagnosis, but I know that this patient somehow, is a diabetic. And then there's the, haven't had a visit, right? So haven't had an encounter this year, but knew they were a diabetic last year. And then there's the third example, which is they're undercoded, right? So last year, maybe they were diabetic, but this year they go in and we notice that they have multiple acuities and we want to be able to account for that. So if you go to the next slide, Mark. So we're going to talk about these particular use cases when Mark shows the dashboard is that sort of revalidation, right? And, patient with diabetes without complication last year, no visit this year. So we need to schedule that appointment. HCC underrepresentation. So again, Mark's going to show a dashboard and describe how we can actually look at how many particular comorbidities or other types of conditions that diabetic has that we might want to code for. And then finally, a new member. What if a patient's new to your plan, and think about peer-to-peer exchange, right? One of the benefits is going to be that you'll be able to pull over that record from your previous payer to you, the new payer, to get that information so that you can actually look at that acuities. So Mark, why don't you take it over and show our dashboard, please?
Sure. All right. Thank you, Linda. So hopping back into the demo system here. Risk adjustment, we're really looking at the scenarios that Linda was talking about, and there's a lot we can do with this data, right? Okay, so it's not so much about the dashboard that we're looking at as much as the underlying data and having it in a clean, centralized place where we can do this type of analysis and gain some insights. So at the top here, we're looking at a simple breakdown of of our cohort, how many have a current visit for the current year, how many are in cohort but don't have a current visit for the year. So this is a gap in care. And then to be complete, also how many of them are new to the cohort within this year and therefore don't fall into the current versus non-current visit mode. We can then break it down further and we can look at, for instance, how many members we have that have various secondary codes that are relevant. And then we can also look at, sort of the severity of our various members of the cohort and see how they break down by how many secondary codes they have. So we have our no code group and then various numbers of codes. And then we can use these to drill down into the actual cohorts, just like we saw earlier. So for instance, from the current visit group, let's see who makes up that group, who's in that, and then we could click through to see their record like we did earlier. We can similarly look at, well, let's look at members that have 2 codes. And again, here's our member population for that. And we could do the similar things for, the prevalence of secondary codes. So this is very powerful to sort of get an at-glance view of how we're doing, where some of the opportunities might be for making improvements, and identifying severity scores that could be adjusted up. But again, this is just a simple high-level look at what we could do, but really the possibilities to do that we have in using this data are just about unlimited. So you could do much more sophisticated scenarios than what we've been seeing here.
Great, thanks, Mark. And again, I want to answer one question that came in the chat while you were demoing, and it had to do with that, providers don't actually often don't have access to the data in their clinical workflow. And one of the beauties of the way our product works is we actually embed it right into the clinical workflow. So we embed our view into Epic, into Cerner, into Allscripts. So we've been able to do that so that it renders itself. And actually, when we show you the video of the work that we've been doing on prior auth, you will see our screens basically embedded into Epic's workflow. So I think that's one question. The next thing I want to talk about was really quickly is inferencing, because this is the other part of risk adjustment, right? This is basically it's a way of drawing assertions from structured data, and structured data can be codified data, but it could also come from, in some cases, NLP data that you sort of get from the notes. And, how can it help with risk adjustments? Well, it's looking for, HCCs that are undercoded because you haven't actually gotten a claim with a diagnosis code and there hasn't been an encounter documented yet. What I would say is you see breadcrumbs of evidence that tell you that this is a diabetic, even though no one has ever documented it as that person as a diabetic. So if you go to the next slide, this was a project that we did. We actually did this with one of our provider customers, but the same concepts apply. So what we did is we were looking for, undetected diagnoses. So we were looking for, patients that had, lab results or things in the notes or, other evidence of, a foot exam, but nobody had ever diagnosed it. There was no actual documentation that said this is a diabetic or somebody with coronary heart failure. But if you go to the next slide, what we actually found is that they looked at 3 hospitals, 100 clinics, a lab, and 4 diagnostic imaging groups, and over a period of 6 months, involving 1 million+ patients. The clinical data from multiple sources. So this was aggregating data, and that's the other thing. So, sometimes you don't get all the data you need to tell the story from just one source. It's coming in from different sources. You may be at a podiatrist to get that diabetic foot exam, right? You go to your ophthalmologist. They may not all be part of the same IDN, but those are breadcrumbs you want to pull together. So what we were able to find is that there were 11 cases of COPD undocumented, 36 of hypertension, 1,300 heart failure where it was never diagnosed yet. It was indicated, all the sort of indications were there. And then finally, 3,500 cases of type 2 diabetes. And again, what the sort of product did is it surfaced it, but then it allowed the clinician to view the evidence and make the decision whether they needed to actually go in and create a note, meet with the patient and document it. So the system wouldn't say, yep, create this and put a diagnosis code to it. It would basically inference and surface that information to allow the provider to make a decision. Next slide. So finally, I want to talk about prior authorization. So InterSystems has been participating for, I want to say it's upward of 4 years now in the HL7 Da Vinci project We have done a couple of pilots with our customers, and most recently, we have been working collaboratively with UC Davis, who is an Epic site, as well as with their partner, Centene. And the whole goal was to automate using the Da Vinci use cases. And I think someone later today, I think Viet's going to be talking about work around Da Vinci. But what I wanted to highlight is how our product was supporting that use case. So if you go to the next screen, I want to make sure we have time. So again, first of all, doing any kind of project like this, even if it's a small scale pilot, takes a village. So there were the 3 teams that came together that created the governance structure. And quite honestly, the governance and getting everything off the ground probably took 6 to 8 months. It was a process that needed to orient it, make sure everyone was ready to go, that funding was in place. But the actual coding and making the pilot work took about 6 weeks of coding us. Every week I would get on a check-in call and they'd say, guess what? We got this part working this week. We got the next part where it would just roll. So I want people to be encouraged that using these implementation guides are not that hard. Getting the right structure and governances, that's where the work is. Next slide, please, Mark. So again, before you see the demo, I want to just describe what you're going to see. So there are 3 implementation guides. The first one is coverage requirements discovery. And what that really is having the provider who's about to order a Botox for migraines to query the payer, Centene, and say, do I actually need a prior auth for this member or this patient who's on this insurance plan? Yes or no? And then the response comes back and says, yes, you need a prior authorization. So that's part 1. You'll see it flow from Epic into HealthShare, and then you'll see the round trip come back from Centene. The second part, documentation templates and rules. Well, what's helpful for a provider to know in their workflow is, all right, if you do require documentation for this particular auth, please send me that documentation and let me know what you require of me in the workflow so that I can provide it to you. So you'll see a questionnaire come back from the Centene system into, again, the provider's workflow, asking them to fill out this questionnaire to document certain criteria. Once that response comes, you'll then see the third part, which is called PAS, or prior authorization support. And that's actually where you'll see the transaction happen and the authorization will again appear as the auth number in the Epic system as an approved procedure. So with that, I'm going to have Mark roll it. This will be about a 4-minute video.
The use case presented here will show a provider who wants to order a Botox injection to treat a patient for migraine headaches. As part of this process, the provider will need to obtain prior authorization for this procedure. The provider has placed an order for the procedure, which is routed to the referral coordinator to obtain the prior authorization approval. On the referral order screen in the highlighted red box, the status is showing as pending review. On the diagnosis procedure screen, in the highlighted red box, it shows the procedure service CPT code listed as 64612 for the Botox injection. A trigger has been built in the UC Davis's EHR application to create the work list in UC Davis's HealthShare application. Once the referral coordinator selects the Generate Now button, it triggers a message to be sent to UC Davis's HealthShare application. The message generated from EHR to HealthShare is an X12-278I message. The referral coordinator will then launch the Smart on Fire application from the EHR system to access the work list in UC Davis's HealthShare application to initiate the prior authorization request. The Smart on Fire application launch point is built into the EHR system via a button called Da Vinci Prior Authorization. When the referral coordinator selects this button, it launches the Smart on Fire application that flows through to the HealthShare application using single sign-on authentication. It authenticates the user while it is displaying this Login in Progress screen. Once successfully authenticated, HealthShare displays the procedure work list along with the status on requested orders. The referral coordinator will then select the procedure from the list to see the details of the order. This screen displays the details of the order and the referral status. To initiate the prior authorization request, the referral coordinator selects the Determine Prior Authorization Status button. Behind the scenes, the CDS hook call is initiated to the Centene server. Next, the response from the CDS hook call is returned and displayed. Under Submission Results, the yellow bar area indicates Auth required. The referral status changes to Pending as additional information is required to obtain the prior authorization. To process the request for additional information, the Centene server sends back the Smart on Fire link Complete Questionnaire, allowing the user to provide additional information required for the prior authorization request to be approved. Centene's Smart on Fire application uses a CQL query to display the additional information needed for the prior authorization. As part of the CQL query, the collection of additional information is displayed. The referral coordinator will answer these required questions, then select Submit. UC Davis's Health Share system initiates a PAS call to obtain the final authorization status and approval code. The PAS call response is returned. The referral status is changed to Approved, along with the approval code for this request, which is displayed as the authorization number 10968. Once the final approval status is received, a message is sent from HealthShare to the EHR system to update the status. This will be an X12278 message. In the referral order screen, the status now shows Authorized. This concludes our demonstration of the DaVinci implementation for prior authorization.
So we don't have time left, but if folks are interested in learning more about what we're doing, how we're working, first, I have to do a great shout out. So the video that you just saw was created by our partner, UC Davis, Michael Marchant and his team created that for us, capturing those screens, but it truly is embedded in the Epic workflow. And we're showing you a lot of the things that would happen under the covers under a normal scenario. The next step is this will be moved to production. So we're actually switching teams from our pilot team to our production teams to start moving this project into production. So again, I don't have time for questions because I know we need to move to our next presenter, but I want to thank everyone for giving us this time.
Okay, on to you, Michael, to announce the next session.
Thank you, Michael. Oh, that was odd. Health information exchanges, or HIEs, are well situated to help healthcare organizations achieve the triple aim of value-based care: improving population health management strategies, providing better care for individuals, and reducing healthcare costs. A more complete picture of the patient population can help providers better coordinate care. Identifying gaps in care and working to close them can help hospitals improve the quality of care they deliver, a staple in value-based care. We welcome Tim Pletcher from Meehan, who is also a Wedi board member, to discuss the general benefits HIEs possess when addressing value-based care, as well as the unique services at Meehan that help providers reach their value-based goals. Tim, welcome to the spotlight. Tim, you should be able to unmute your mic.
All right. How's that? Trying really hard. Is there a way for me to get my camera on too? That would be
yes. You also have that, yeah. You have that ability to.
It's definitely not coming on, so I'm not seeing where that's working.
Yeah, you are a co-host, so.
Are you able to get the camera on?
No, unfortunately, I can't do that. But let me do this. Let me take you.
Okay.
Up.
Bottom left, Tim, of the screen.
Yeah, start video.
Start video.
Bottom left.
Or next to your mute for your audio control should be a start video for video control.
Not. There we go. All right. I got the proper full screen on.
Touchdown. There you go.
All right, great. Hey, is there a way for me to sort of share my slides as well?
Yes, you should see a share. Or here, let me do this. Let me stop my share. Actually, you should be able to share on the bottom on that same toolbar. There should be
Perfect. It just started. It just showed up. That's great. Yeah, and I'm gonna whack you, and then we'll jump in. Sorry for the delay there.
Excellent.
Not able to. Are you able to see that or not?
See the slides, but it still looks like you're in preview form.
Yeah, it's.
I have to go view full screen or something like that.
Yeah, let me, see if we can restart that. It is not letting me bring that app to full screen mode at all. I've never had that happen. Let's see. So for some reason. It was beyond my comprehension. I'm gonna apologize for that. I can't make it work.
Would you do this? If you're still up, email them to me, and you can.
I have emailed them to you. You have them?
If you email them to me, I don't have them. Right. Did you email them to me recently?
Yes. Let me just.
And then you can begin, and I'll just pull them up.
All right. It's like your machine. It's like Zoom has control of my machine in a strange way.
All right, I got them right here. Go ahead and begin. Give a little intro, then I'll pull them up.
Okay, great. Thanks. My apologies for the rough start there. I will stop my sharing and let you pull them up. I'm Tim Pletcher. I'm the founding executive director for the Michigan Health Information Network, and I'm going to walk through and a recent Wedi board member, and I'm going to walk through just a little bit of what the value proposition is for value-based care for an HIE, kind of in a general sense. And I'm going to kind of talk about the sort of infrastructural components of HIEs and how they really lead into the sort of journey from perfect. If you go to the next slide. Just quickly, MyHIN, a state designated entity, one of the original HIEs funded by the Office of National Coordinator to really create infrastructure for health information exchange, founded out of the state of Michigan. Next slide. And one of the things that we're really focused on is creating infrastructure versus just getting data from point A to point B. And the difference between infrastructure is sort of the scalability of it, the ability to do things at a level that haven't been done before, and to layer new services and new foundations on top, new capabilities on top of that infrastructure. Next slide. And the basic tenets of HIEs is you do things once and not 50 different ways. And you create these sort of hubs to get things to scale. So you reduce a lot of the duplication and a lot of the burden of doing things again and again different ways. The basic tenets we've always done for, you know, our sort of X12 standards, et cetera. But doing that legally, doing that technically, doing that sort of workflow kind of perspective. Next slide. The problem that we've seen in the HIE space in particular is it's a lot like the tragedy of the commons, where the different activities have different value. It's very, very common for the government or for a health plan to see huge value in an activity, but it actually reduced the productivity of a provider, and in some cases even lead to a revenue decrease, which is great if you're a payer. But sometimes that savings and extra work doesn't necessarily find its way back to the provider. And so a lot of what we wrestle with in the HIE space is this sort of mismatch of different value. And when we talk about value-based care versus fee-for-service, the dynamics shift a little bit, which is good for HIEs, because it's actually very hard to go to folks and say, please buy my product and services so you can lose revenue. It's a hard argument to make. And a lot of times when you're saying we're trying to make the whole system more efficient, it actually means we're pulling cost out of the infrastructure. So we keep this very much in the forefront of our minds. Next slide. Now, HIEs have had a long history, when it was from CHINs to RIOs to sort of health information organizations and HIEs. But there was sort of a watershed moment, sort of the moment when we realized that having infrastructure that you can rely on to quickly solve real world problems where everybody is temporarily aligned was COVID. Where HIEs were in place, where that infrastructure existed, absolutely everyone agreed that that infrastructure added value to sort of public health and just helping us with the COVID pandemic, whether it was the ability to quickly get labs on board or to relay who has COVID or who's been vaccinated back to all the different folks. That was a watershed moment of why you want infrastructure and how it can do amazing things quickly if you're sort of got all the stakeholders aligned on solving the same problem. That's really led to, in 2022, this concept of a health data utility and sort of where does that infrastructure go? And next slide. One of the things that's different about a health data utility is it takes the success that has happened in sort of the HIE space and beginning to sort of expand that footprint to get reusability and standards and get sort of closer into the community. If you go to the next slide, there's sort of a bigger picture for us to read there, but sort of traditional HIEs have often found themselves in almost competition with EHRs, where they're trying to really solve for getting providers data. And more, as we get more interoperable, that initial circle is being solved by interoperability inside of our EHRs. But as we kind of look at those more expansive HIEs, they're starting to really round up a lot of the other actors who are not all on the same system, who are not using, you know, the sort of major EHRs, in some cases might not even have an EHR. And then we get to sort of the definition of where folks are headed with the health data utility. And that's this much bigger circle of community-based services, and I'll call them almost non-traditional audiences that, as we sort of look at chronic care and we look at sort of health and well-being, really create an infrastructure that can scale the entire state to provide a wealth of services and a wealth of interoperability, and even person matching or client matching, as some of the community services call, that has really been absent as this sort of digital transformation really happens to keep people well, much of which is outside the traditional walls of a hospital or a provider's office. Next slide. And so this infrastructure starts to really create a feedback mechanism for us to sort of learn to do quality improvement initiatives and ultimately even enable a different kind of research. Next slide. Now, the problem that we've seen historically is, and this is one of the great Da Vinci slides that basically shows the sort of transition to sort of value-based reimbursement versus fee for service. And then there's this little piece in the middle for this transition period, which is taking unbelievably long in some cases and is certainly unevenly distributed where it's a major driver for activity. And so it can get talked about a lot in some cases, or it's just now reaching some level of critical mass for a number of folks. And so we've been really trying to balance this space as this transition occurs. Next slide. And to that end, when we look at how we have cost recovered, traditional fee for service to sort of send data and be a good citizen has really not been something where we've tried to cost recover from. Same thing for sort of modest gap in care quality incentives. It's really getting people to share data and use data has been driven by those who benefit the most, which has historically been sort of the government or the payers. But as we migrate to more of a risk-bearing structure with full capitation being completely at risk, then it makes perfect sense to sort of let them bear more and more of the cost for things, because essentially they care about getting that additional data and actually being able to use it and close a lot of those feedback loops. And so this sort of shift toward value-based care and shift toward risk is also where sort of the shift for understanding where the value proposition is for folks. Next slide. Now, where we're seeing a lot of energy is around trying to understand how everyone is connected. And payers often refer to this to attribution, but it's much more comprehensive in a value-based care arena, where if you go back, where we're really trying to understand how a person fits into the rest of the ecosystem and tracking the connectivity for the patient. In the Da Vinci test, this is sort of the roster kind of function, but it's really mapping which person is connected to which entity, which providers, and what are the endpoints, or what are the electronic destinations you can go to get information or to send information to each of these places. And we refer to this as the active care relationship service, and it is a full care map of how a person fits into the larger ecosystem. And as we go to a health data utility, you can see how this map of how a person is connected to the rest of the ecosystem becomes increasingly important, not just to know how they fit for optimal treatment, but to where to go to get data, where to send data, and particularly as we look at a fire world, where might there be fire servers and endpoints to pull the pieces of information we need from kind of a master directory perspective. Next slide. Now, one of the recent problems we've seen is establishing norms around healthcare operations. If someone has what we call an active care relationship for treatment or payment, it's very clear. But when someone wants to establish a registry or a quality improvement initiative across multiple organizational boundaries, this has presented us a challenge for trying to figure out how to enroll a person's data into that process. Next slide. And so this has really evolved to, next slide, where we're bread and butter HIEs has been moving the data around, closing some of the basic gaps in care at the provider level. As we slide into this next level, it's really population health. If you click for me, Michael, click again, population health, and pulling that clinical information together. And it really starts to take us into that value-based care level. But now one level higher is this entire bucket where we start to look at specialty quality improvement arenas becomes combined with sort of the population health level, if you'll click again, Michael, to really outline where the value-based care layer is that sits on top of the HIE capabilities. And this is sort of where the magic is of knowing how people are connected and where the important synthesis of the data has to come from to be able to say this person goes into this category over here or is better served for this treatment. And then these clinical quality improvement areas are a big deal for being able to try and build registries and sort of comprehensive best practices that sort of layer in on top of the rest of the information as a specific focus, like diabetes, like some kind of chronic pain, like suicide prevention. There's many of these different areas that you really are trying to zero in on best practices for. If you go to the next level, the same infrastructure stacks for research and clinical trials, but that's not where we are as an organization at this point. Next slide. A lot of our work has really now been recently on processing pre-adjudicated claims to minimize the amount of clinical information we need to look at to decide if somebody should be in one of these specialty programs. And so if you go to the next slide, what we've really begun to do is look at the pre-adjudicated data. There's a sense of it's a little more timely in many situations to sort of figure out, well, can we get an early warning detection that this patient meets a certain criteria for a quality improvement program that would justify us doing sort of a deep dive in the longitudinal record to sort of pull out and say, this is a person of interest to the quality improvement team. Next slide. And it's taken quite a lot of integration to be able to pull the data appropriately from the claims clearinghouse at that pre-adjudicated level, to look at it sooner, just like we also use ADTs as sort of a admit, discharge, and transfer as sort of early warning to really figure out, should we be scaffolding this person to be targeted for inclusion in one of these quality improvement initiatives. If you go to the next slide. And so this is sort of an expansion of that map of how a person is connected to the rest of the ecosystem to really say, okay, here's a particular registry that we now need to populate and pull the data for and include this person's data in. And I saw a couple of questions about consent. There's a whole elaborate set of consent processes that go in here. This is sort of after consent, still finding their data and knowing that they qualify for the registry. And then we establish this other linkage, if you will, so that everyone can see that they're in this registry, access that data in the registry, but also we can continue to sort of subscribe to the flow of information to populate that registry. And typically these registries are maintained by another organization someplace. And so what we're really trying to do is make sure we've got a consistent and predictable way for that data to get populated there, that all the other stakeholders, including the patient, can sort of understand and see in a predictable way. Next slide. And we call the process for sort of objectively figuring out whose data can be in a quality improvement registry scaffolding. And in that scaffolding process, a quality improvement initiative really will articulate the enrollment criteria, and that'll go through a whole series of approval processes. And then what will happen is we'll look at those pre-adjudicated claims, we'll look at the ADT type events and say, do they meet the minimum standard for being worthy of digging into the clinical information? If they do, if they meet that initial scaffolding criteria, we'll then go into the clinical information, apply the rest of the clinical criteria, and then kind of pull that patient out and essentially recommend them to that quality improvement program. Next slide. And what this ends up doing is it ends up providing a really systematic mechanism to identify where folks are going to get the best opportunity for quality improvement, which increasingly is a critical function for anybody's value-based care initiative versus beyond just closing gaps in care. There's this sort of real need to improve overall practice for particularly chronic conditions and coordination of those. But it often becomes, how do we create a mechanism where my quality improvement program can legitimately get access to data that is coming from different places? And the HIE is a natural place to sort of aggregate that information and pull it together. But we really want to standardize sort of systematic and objective processes for that data to be both allowed to move into that quality improvement initiative and to be automatically moved in if those criteria are essentially met. And there's sort of a whole legal chain of trust that goes along with this, but it ends up creating a mechanism to take ADTs and supplemental clinical information and claims, pre-adjudicated claims data to, on a minimum necessary basis, sort of move people along to get that data in that healthcare operations setting that allows different organizations across the ecosystem to sort of collaborate around a particular quality registry kind of effort. All right, let's stop. Let's go ahead and stop there just in the interest of time, Michael, and I'll answer questions.
Excellent. Thank you, Tim. We do have one. Oh, we have several, actually. Let me start with, how do you gather patient consent at the point you collect to share the data with other entities?
So in our legal structure, every single organization who connects to us basically collects those consents, okay? And then they basically can't even propagate the data if they don't have the right kind of consents in place. So there's sort of that first barrier. And then for each of these registries, they have a pretty elaborate opt-out kind of process, which can kind of push it back even further. We are kind of in the middle, so we don't really have a patient-facing outreach to sort of give us your data. We're really collaborating with all of those folks who are basically the end providers around the data, and they sort of control the access and the use. So like you couldn't be a third party who just shows up and says, hi, give us your data. You kind of have to be part of the community and the ecosystem for this.
Sounds excellent. Thank you. Any additional questions for Tim Pletcher with MyHin? Just marinate for a second. And I believe you wanted to talk a little bit about kind of the HIE, Civitas, kind of HIE's association and what they do in terms of assisting HIEs and folks throughout healthcare.
Yeah, so I just you know, Civitas is the sort of industry association for HIEs and for but, you know, over the last few years, Civitas has really become a new organization that's brought in other stakeholders and begun to really advocate for this concept of a health data utility that I mentioned at the beginning. And it's got, you know, literally now hundreds of organizations who are working at various different levels to take the HIE model and the health data utility model and you know, help folks understand the true benefit of the infrastructural components of actually having a persistent place in each jurisdictional region, like such as a state, for being able to layer in data and have consistent approaches like this scaffolding process to sort of say who can have access to the data, but also guaranteeing that public health has access to the infrastructure it needs to sort of quickly do things like the pandemic or other health equity kinds of agendas, where you're really trying to make sure that there is pervasive access, appropriate pervasive access to sort of a shared data utility at multiple levels, so that a community-based organization can do you know, coordination within its local jurisdiction, but they're not trying to pay for a separate MPI or a separate infrastructure that won't be interoperable with the next county's or the next city's infrastructure, but that you can actually, you know, crosswalk from, I'll call it the traditional healthcare arena over into the community-based arena, where the worlds are different. The expectations are different. You know, many community-based organizations are trying to feed people first. In healthcare, a lot of times we'll talk about the social determinants of health and health equity. We're coming from the healthcare perspective into the community, and we're interested in our narrow piece. The community has got its own agenda, and what we're really trying to do with this health data utility infrastructure is create a common meeting places where those two worlds can reuse interoperability, reuse shared infrastructure, and not go off in directions that end up with sort of multiple silos.
Sounds fantastic. We thoroughly appreciate our relationship with Civitas and with you and the folks over at MyHin. Tim Pletcher with MyHin, thank you once again for a fantastic presentation, allowing us a little window into the work that you're doing in value-based care and so much more. So thank you once again, Tim. We truly appreciate it. And with that, folks, we've come across time for a little bit of a break. Let's come back at 1:15 p.m. Eastern with the rest of our sessions. We'll be starting off at 1:15 with Dr. Robert Groves with Banner Aetna. So feel free to stretch your legs, grab a snack, check your emails. We'll see you in about 30 minutes or so.
Okay, we're at 1:15. Welcome back, everyone. So today we are joined by Dr. Robert Groves. Dr. Groves is the Executive Vice President and Chief Medical Officer for Banner Aetna. For the past 7 years, Banner Aetna has been driving innovative and collaborative value-based care models. These unique models that are not yet categorized by HCP land are driving innovation, improved outcomes, reduced costs, and greatly enhancing the patient's experience. So, Dr. Groves, welcome. And could you please just introduce yourself, your 30 years historical Banner, before Banner, and just give us a high-level description of what a provider-partnered health plan is. What was the original goal behind creating the Banner Aetna joint venture and partnership?
Thank you, Michael, for the opportunity to talk about this. Yeah, I'm trained as a pulmonary critical care doc and spent a total of about 30 years in practice, with some overlap between my active practice and my administrative adventures, initially with Banner Health on the delivery side, and subsequently now for the last 5 years with Banner Aetna. I did have the opportunity to practice in single specialty, multi-specialty group, and delivery system owned practices. So I've had a variety of experiences there. And on the delivery side, I worked with Banner Health, which is now about a $10 billion integrated delivery system. It's based in Phoenix, Arizona. And I started out rolling out the EICU in that organization and wound up as the vice president of health management before moving over to Banner Aetna. To describe Banner Aetna, it is literally a joint venture. It is an independently licensed insurance company named Banner Aetna that leverages the strengths of both organizations. We have 50% ownership, 50% Banner, 50% Aetna, and equal representation on our board of directors. So this is aligning incentives in a different way than perhaps what most people think of, but Banner now has a vested interest in the performance of this portion of the insurance division because they're half owners. And so they split the profits, or they split the debts, depending on how we land at the end of the year. And that changes the dialogue, changes the conversation significantly between the two. What had been adversarial is now a collaborative relationship. I don't think we would have been able to take advantage of, for example, many of the CVS offerings with minute clinics, health hubs, et cetera, if we hadn't had that relationship, because in the prior setting, that's simply competition. Here, we can figure out how to align our resources to dramatically enhance accessibility.
Yeah, that's great. And I don't know if everybody can tell I'm smiling a lot. I'm a big fan of Dr. Groves, and we'll talk a little bit later before the end about some other ways you guys can get more information. But thank you, Dr. Groves, for that introduction. But before we get into the great work that's being done at Banner Aetna, I'd love to get your view on the healthcare industry as a whole, and more specifically, our drawn out move to value-based care. In March, you released a report in the American Journal of Accountable Care that shared some pretty impressive metrics, but you started the report with healthcare has drifted far from its roots. What are we doing wrong? I know everybody wants to see value-based care succeed, but what's your perspective? And it's always great to get both sides of the coin here. So,
yeah, Michael, thank you. I think we forget, and in survey after survey, if you ask what patients really care about, number one always is caring. Patients understand that we cannot always cure, but what they want is somebody who cares, who's interested, who has their best interests at heart, who is willing to spend time with them, to understand what their needs are, and to show that level of caring. And, you know, with some of the necessary changes that had happened in healthcare, I think we've lost sight of that. And, you know, much of what we do now is focused on, you know, how do we get the metrics right to make sure that we have optimal compensation? How do we bill more, charge more, so that we can make sure that we have a sustainable system that makes a profit at the end of the year? And that's all well and good. You know, you have to have sound financial principles to operate anything. But unfortunately, we've gotten away from what is the core value for both patients and physicians, and that's the relationship, ideally, between a primary care physician and a patient. That's what has the best potential to influence behaviors. And as you saw in an earlier presentation, behaviors are far more important than the $4 trillion we spend on rescue medicine that we call our healthcare system, in determining outcomes that people care about, lifespan and health span. So the question for me is, how do we get back to enhancing that relationship? And part of the answer is that we need to think about technology as a tool that supports the relationship, not a replacement for the relationship, but rather a tool that supports the physician-patient relationship, which is where the magic happens.
Yes, and we've discussed before, most of the models today are all still based on fee-for-service, right? So underlying, there's that fee-for-service churn, or that gerbil wheel, or whatever, treadmill I think you've used in the past. It's probably better than the ones I used. But you know, we need to move away from that fee for model. Is there anything you can give us as far as, you know, how the industry is attacking this now, how maybe Banner Aetna is?
Yeah, you know, Michael, this is a really important point. In the way that we pay physicians currently in the context of an EMR that really wasn't designed for clinical care. It was designed primarily to ensure accurate coding and billing. And it's no wonder that most people don't have a primary care relationship anymore, when all you get is 10 minutes of a doctor staring at a computer screen and telling you what your metrics are. That's not, I think, what any of us would sign up for willingly. You know, there was a JAMA report that came out recently that identified that 50% of docs now work for one of these large delivery systems like Banner, and that 90% of their pay is still based on fee-for-service, or RVUs, as an alternative to straight fee-for-service. And even the alternative payment models, many of them are still based on a fee-for-service model where RVUs are tracked doggedly to make sure that doctors are performing. And that's what we call an external motivator. And most physicians have very powerful internal motivators that we have suppressed in our zeal to optimize productivity. So I think we have to get to a system that rewards physicians for their work fairly, and that does so in a way that doesn't incentivize or disincentivize the wrong things. You know, there's a book called The Tyranny of Metrics. I wish I could remember the author, but we need to remember that if whatever metrics we set up, if they're highly dependent, if the users of those metrics are highly dependent on them for their income, their promotions, whatever else, those will be to some extent gained. It's inevitable, it's human nature. And so what we get is a distortion, and the fee-for-service distortion is very clear. It's to do more, to make sure people have as many diagnoses as we can give them for risk adjustment. And all of those things add up to a system that doesn't care about me as a patient. So I think we need to get to a form of population-based payments, or even, you know, I think we would do fine if we put physicians on salary, much like they do at Kaiser. The internal motivators are so strong in physicians. If we give them the tools that they need to support the relationship, if we give them the teams so that they can scale their interventions, and we give them the trust to manage that, yes, let's use metrics, but use them internally so that physicians begin to manage themselves. We're all overachievers. We don't want to be the worst physician in the group. We want to be the most efficient, highest quality physician we can be. You don't need to base our pay on that. What you need to do is just show it to us, and we will respond and perform.
Yeah, I think I remember you saying all doctors are always going to do what's right. And I loved listening to one of your webinars where you spoke about your dad and how you used to go on the rounds as a young child. So yeah, we really need to return back to, where the doctor was, really close with the patient and listen to it. We're just really getting away from it. So another subject for another time, but we should really move on since we only have a little bit of time with you. I'd love to hear a brief history of the innovation, the value-based care work that Banner Aetna has accomplished, and just bring us up to speed on what you're doing today to make that transition easier for your company.
Sure. Banner Aetna caught my attention specifically because the intent was to begin to fix healthcare. I mean, we have a series of fundamentals that we go over every week, and I write up a little blurb about the fundamental and unpack it a little bit for the team. And our first and foremost is we're here to fix healthcare. And our CEO has said over and over again, if we are wildly financially successful, but we haven't made care any easier or any better, then we will have failed. That's not what we're here to do. And so how does that look? Well, one of the principles that was established early on is we want to push those functions that make sense to be owned by the delivery system. We want to push it over to them. And so, historically, case management for hospitals has been once the patient's admitted until they're discharged, and it was left to the insurance companies, the payers, whoever they might be, to provide particularly on the commercial side, to provide the case management outside the hospital. And so what we've done is reverse that trend. And we've said, no, listen, we've got something we call the multidisciplinary care team that is very focused on that top 5% high-risk patients that account for around 50% of the cost. So we have obviously sophisticated analytics to help us identify those folks. And we identify them after admissions or after a couple of ED visits, and we say, okay, this is somebody who needs our help. And then we deploy that team. Well, historically, and by the way, that team is pharmacists, dietitians, nurses, physician-led. And that team historically has lived on the payer side. Well, we've pushed that over to Banner and said, you're in a better position. The landscape locally, it is your expertise, how to deliver excellent care to the patient populations that you serve. You take this on. Same thing is true of utilization management. So about half now of all concurrent reviews and prior authorizations are done by Banner Health physicians on the delivery side. And some would say, well, isn't that the fox watching the hen house? Well, absolutely not, because Banner has a vested interest, again, in the performance of this co-owned company. And so what we found is that Banner performs as well as Aetna in terms of the end game. But what we also found is that there are far less delays due to inadequate data, because Banner has access to many of the charts and records. They can, in real time, if there's a question in their mind, they don't have to send out a query, wait for a doc to respond. They can look it up, and there it is. So that's one of the principles, is push those things which ought to be delivery over to the delivery side. The other is that we can be a hub of innovation, if you will, because we're smaller and we're not the behemoths that Aetna/CVS and Banner Health are. We can move more quickly, and we can trial strategies that seem attractive. And then if they work, we can scale those to our larger partners. Examples of that, we were the first payer to contract with a company called 98.6. They were the first to do a fully text-based on-demand service for telemedicine. We've introduced Virta Health, the first company to show that it's possible to reverse the diabetic process to get people off of their meds instead of coming up with a new med. What this company is doing is, 60% of participants over the course of a year get off all diabetes medication. It's a lifestyle company that is comprehensive in its approach. So we can trial new and novel strategies like this. We're working on prior authorization now, looking at a variety of tools and techniques that are out there to try and simplify a process that nobody loves. And then we're also looking at frictionless billing. So we're looking at every aspect, make it easier to do business with us. We have navigation pages now for diabetes and behavioral health, where the number of point solutions can be overwhelming unless they're categorized, and we allow folks to actually look at what's available for them right now, what's available on their plan. So there are a variety of strategies that we've undertaken. We also know that we have had the lowest costs, and we are, as a result of that, the fastest growing health plan in the market over the last 5 years. It's not hard to understand why. We're really trying to make things better for patients, for doctors, for everybody involved in healthcare. Coordinated systems so that if you call in, you can not only get answers about your claims, but with warm handoffs, you can get answers about your clinical data. So it really does make sense in a market like Arizona for a company like Banner Aetna to lead the field. And that's what we hope we're doing.
Yeah, absolutely. And with interoperability, with payer-to-payer communications, it's only going to get stronger as, you know, members, patients start to roll into the Banner Aetna, and they can still have that historical come along with them. So it's really a great model. And we've talked exclusively about the 550, right? The 5% of your members costing half of your costs. And payers for years struggled, right? They bypassed the providers and the hospitals and the health systems, and they tried to go directly to the members with 400, 500 in some cases, nurses trying to do complex case management, care management, disease management. And the model that Banner Aetna is accomplishing these days is bypassing that. From that report, I saw the numbers went up from 30 to 60% of outreach and actually getting folks into care plans and starting to, you know, knock down some of the barriers there. So it's quite impressive.
Michael, let me ask you, I mean, if you get an unanticipated call, one is from your health insurance company, the other is from your doc, which one are you most likely to answer? You know, this is not rocket science. It's human behavior, basic human behavior.
Right. Yeah, one's looking for money, the other one's looking to make you healthy. But, you know, unfair to the health plans. I mean, I've worked, that was part of my job, was care management, predictive modeling. So I've even seen you mention that what Aetna brings to the table, all those good tools, predictive analytics, they're all being now utilized. So it's a seamless between Banner and Aetna. It's just a collaboration, a partnered solution that you know, we'd love to see more. We'd love to see it modeled further. And as you mentioned, you're a small, nimble, you're able to, you know, incubate these ideas and then move it out broadly to the Aetna CVS world. So looking forward to more. So we still have some more time. So I'd love to, you know, what does Banner Aetna's future look like? You know, with that unique relationship and national support from both Aetna and CVS, you know, how are you poised to continue on this evolution?
Yeah, you know, we are in the early stages now of talking about population-based payments to Banner providers, you know, to put our money where our mouth is, if you will, and work on that. You know, this is not to say that any of this is easy. Healthcare is incredibly complex, and we as human beings developed a status quo bias for very good reason. It's you know, it's energetically less demanding. You know, we feel comfortable with habits that we've adopted over time. We know what to expect. We make less errors when we're comfortable with the environment. So change is hard, but we continue to push inexorably towards what I believe are solutions that will actually help us move the ball down the road in terms of giving patients what they really want. They want time with their doctors. They want time with a caring physician, with a team of providers who has their interests at heart. And I think we can get there. I don't think that it's going to be easy because a lot of the systems we currently have are entrenched. But other things that we're doing going forward, we're looking at creative strategies to influence behavior. And it's interesting. And when you raise issues like that, and I've talked before in physician forums about notions like psychographics and behavioral economics, et cetera. And people are a little gun shy of that, and they say, well, isn't that manipulation? Well, if you're using it to get me to buy the latest gizmo, yeah, that's manipulation. But if you're using it to help me accomplish my own health goals, I call that a positive influence. And believe me, pharma's using this to sell drugs, and systems are using this to sell their services. Why not use those same insights and those same tools to influence behavior? As you heard, 30% or more of our health outcomes have to do with behaviors. What are you eating? How do you sleep? How do you manage stress? What's your connection to community? These are basic human needs that drive health far more effectively than the rescue system. Now, that's not to denigrate the rescue system we have in place. We've accomplished amazing things. It adds an average of about 8 years to the lifespan of the typical American. So I'm not going to sneeze at that at my age. That's important. But it's still rescue medicine. We're way downstream. The horse is already out of the barn. What do we do to back up and start really improving health? The only way that you can do population health management well is to actually improve the health of a population. And you do that through behaviors, through influence, through relationship, through connection. I don't think there are any bad players in healthcare. Well, okay, there are a few. But for the most part, it's good people doing the best they can to deliver good service following the incentives. If we want to change what we're getting, we have to change the incentives. We just must. Otherwise, we'll continue to get what we've gotten. People say, well, value-based care hasn't worked. We've been at it now for such a long time. And I will remind you that we are not anywhere close to paying for real value. When most of even the CMMI strategies depend on coding, it's just too easy to say, well, what are your RVUs this month? Are you a productive physician? How many more patients can you see in an hour? And that's just not a solution to the problem that we're experiencing now.
Yeah. And I've heard you say that there's no bad, the payers, the providers, the patients really want to do well by themselves. And there are those few bad apples, and fraud, waste, and abuse policies should snag them eventually. But yeah, I know technology innovation has been a large part of what you've brought along in your long career here. Are there any software products? I know you mentioned there was a you're looking for a prior authorization system. The folks on this call are really interested in interoperability, data sharing, tackling some of the heavy problems like value-based care, health equity. What's your take on technology helping us solve or get better with value-based care?
Well, technology is essential, right? This is not something where I'm suggesting we go back to the old model of, I'll use my best judgment as a craft-based, physician to craft a plan just for you and hope I get it all right. I mean, information in the 1950s took 50 years for information to double. Now it's measured in months, if not weeks. There's too much changing for us to be able to keep up without technology. I'm excited about the introduction of AI. I'm excited about analytics. One of the major problems we have that any clinically integrated network has is that we're not just talking about Cerner and Epic and a handful of EMRs. We've got 30 EMRs across our aligned physician groups, and they account for roughly 70-75% of the services that we provide. So we've got to bring all of that information together, clean it up, and make it relevant. And then here's the trick. translating that data into information requires us to be very thoughtful about how, where, and when it is presented to caregivers. If that information is just a bunch of bars and graphs, first of all, the caregivers don't have time to look at that. And second of all, it's going to take them some time to just understand it. That stuff should be behind the scenes, and relevant, actionable information is what should be presented to the physician at the point of care. That's what we're working towards. Data should serve human beings. Systems should serve human beings, not the other way around.
Yeah. And I have a good friend, I believe you've spoken about Holon before, where they can actually bring that data from all those disparate EMR systems together, and in a way where it's not intrusive to the workflow. So there are technology out there, and I'm glad that they're being discovered. Small companies, big companies.
Yep, and we are always on the lookout for innovative solutions. I mean, but the path is a difficult one, Michael, because entrenched interests don't give up easily, and nor would I if it were my company, right? It's like, wait a minute, we can do that too. And so bringing in point solutions can sometimes be a real uphill battle. Verta Health is a great example of that. Bringing that in was a challenge. Bringing in systems like Holon and others that can span all of those EMRs is no simple task, because what clinicians hear is, oh, you want me to sign on to one more page and have one more thing to do in my day. I'm already overwhelmed. I can't take care of patients because I'm doing administrative tasks dawn to dusk. I think there was a recent survey that suggested for every hour of patient time, physicians spend 2 hours in documentation. That is upside down at best. And so we need to get there. I think there are companies that are working on solutions, virtual scribes. We are keeping our ear to the ground to look for solutions like that make it simpler for clinicians to do their work, that capture the patient visit automatically so that there's not a 2-hour workday after you finish your workday to finish up on documentation. There are countless opportunities. I'm very optimistic about the future. But we're just in that in-between phase right now. That's the hardest place to be, 1 foot in each canoe. We've got to get past this. We've got to get to a real value-based payment. When I say that, read population-based and or salary. Those are and you ask, well, how will you set the salary? Well, that's the other problem, right? We need transparency, and we need to be able to understand cost, pricing, to create a true market where competition can take place. We don't have that today. We're moving in that direction.
Yeah, I'm glad there's a lot of conversation about provider burnout, because we need to address that. I believe there's policies in place and coming down that should address that. So I think that's great. Now, I don't think I see any questions here, but Dr. Groves, on behalf of myself, Wedi, InterSystems, our sponsor, we'd really like to thank you for joining us today, offering us all, I hope everybody was taking notes, the insights into an alternative model that is actually succeeding in value-based care. So I'd like to make one shameless plug. I've been really consuming Dr. Groves has a podcast. It's called The Groves Connection. I believe you can get it on Spotify, Apple, Amazon Music, Google Podcast. There's a whole bunch of ways you can get to it. They're so informative. They're great. They're produced well. I believe your son does some of the producing. So a really good time to go in and look at that. Do you want to end us off with any thoughts on?
I'm so happy that you invited me, and so happy that I had a chance to meet you and others in the organization. I've enjoyed the presentations today. I have some new ideas as a result of visiting with you guys, and so I'm excited about the future. And I think we've got a lot of work to do, but hey, we're up for the task.
Great. Thank you so much, Dr. Groves. I really appreciate it. Michael, any questions popping in?
I don't see any. This was a fantastic session.
Terrific. Thank you. I think we just laid it all out there and had the answers already. So terrific.
And our next.
All right,
speakers
thank
are-
you, Michael.
Thank
Thank
you,
you.
Dr. Groves.
And Michael, our next speakers are ready to go.
Oh, terrific. All right, we got the splash screen up. There we go. All right. Well, as you can see, blazing the technical pathway to value-based care, the HL7 Da Vinci project has been paving the way for increased data sharing between payers, providers by leveraging the FHIR standard. From opening up healthcare data to consumers and enabling payer-to-payer transfer of data, Da Vinci is improving accessibility and interoperability for a number of years now. Today, we'll be hearing about the great work the HL7 Da Vinci project is working on that will be vital in the industry's continued transition to value-based care. I'd like to welcome our two speakers, Dr. Viet Nguyen and Samira Singh from Providence, to offer more insights on Da Vinci and its place in supporting and integrating value-based care data exchange.
Well, thank you very much. Can I have a sound check? You can hear me okay?
Yes, we can.
Excellent. Well, thank you, Michael, for that introduction. And thank you to the Wedi community and your sponsors for inviting us back. I think over the past 5 years or so, we developed a really great and collaborative relationship with the Wedi community in both the drawing from the community and getting your expertise and helping us develop standards that meet the needs of the industry, as well as your participation in helping us implement it. And so we're pleased to be back to talk about the topic of the day, but really what we're doing here in the Da Vinci project to address the technical approach to doing value-based care. And so with me today is my good friend and colleague, Samira Singh, who is part of Providence and has been a leading member in the Da Vinci community to help identify the needs of the provider community and participating in the efforts to develop our FHIR specifications. And she and I were actually just on a call a little earlier today on this exact topic as we're trying to advance our work and bring it to the broader audience of the HL7 standards community, as well as the health IT community. So with that, I'd like to go ahead and have Samira introduce yourself. Samira, tell us a little bit about your role at Providence and the things that you're supporting in the kind of transition and journey in value-based care.
Sure, absolutely. And to second what Viet just said, thank you all for having us. So in my capacity, I serve as a product leader. I focus on value-based care, interoperability, strategy, and product development for 150 or so contracts. So being a large healthcare organization, if you're not familiar with Providence, we span about 7 states. We have a lot of provider groups, a lot of hospitals, and we are extremely interested in value-based care. We've been focusing on shifting from fee-for-service to value-based care over the past few years. And I think that our work through Da Vinci is essentially allowing us to exponentially increase the speed at which we're able to do some of that. So we're really excited to talk to you about this today.
Thanks. So we're going to kind of do this in a conversational approach with some slides to help kind of ground the conversation. And so Samira's colleague at Providence, Deepak, is on our steering committee, and he introduced a use case. Da Vinci, gathers use cases from our member community and the broader community, and really asked us to look at the challenges that providers and payers have in exchanging contract-based metrics, I'll say. And we really promoted this, and we realized that, yes, we started Da Vinci 4.5 years ago. It was really around value-based care, and we've done a number of activities. And but this year we decided we'd go back to our roots around value-based care. And we know that the term value-based care is used pretty broadly. And as you know, many of you know me, I'm a terminologist and terminology matters. And that we wanted to get grounded on what do we mean when we mean a value-based care relationship. So one of the early work that we did the first half of the year was to bring a number of our members together and say, what do we mean in Da Vinci when we say there's a value-based care journey? And to start to come to an agreement, and I jokingly say, if we can get 9 out of 10 Da Vinci members to say, yep, these things that you identified, I'll agree that this is part of the journey. There's probably more. And so we gathered this group together in a series of calls and laid out what we'd like to say is kind of this journey that has a number of phases, a number of components, inputs and outputs. I won't elaborate on them all, but I think this journey mapping has helped us to identify where we have already developed guides to support the journey and where we have work to do. So Samira has been a great participant in this. And so I thought, Samira, could you highlight for the audience the areas where you thought that we needed to elaborate on the details so that we can come to an agreement on the workflow and the things, and where the opportunities are for us to develop some standards around this journey?
Sure, absolutely. So as yet briefly mentioned, there's a lot of work that Da Vinci has done over the past few years to implement or create implementation guides to streamline the way that value-based care data is exchanged. And I think your next slide, there we go. Yes, I think your next slide highlights some of those. So I think looking at this from a provider perspective, your first component of establishing a value-based care relationship agreement, I would imagine that in that phase, you're working with your contracting departments, your legal departments, your HPN, so high performance networks or clinically integrated networks, any other bodies that are essentially involved within contracting to establish what this value-based care agreement is going to look like. You may talk about things like, is this going to be upside only risk? Is there a quality incentive or a gate? How much money can we afford to pay if we perform poorly? Just your basic understanding of your value-based care agreement and coming to terms of what that agreement actually means. I think your second step there is, okay, so you have this agreement, you need to engage in some sort of data exchange. As a provider, you need to fully understand who your members are. Whether you're using that data outside of your EMR or whether that data is being loaded into your EMR so that you have the information at your fingertips for outreach, you need some sort of list that is updated on a regular basis, preferably monthly, to tell you who your members are. In this case, we already have a Da Vinci value-based care member attribution IG implementation guide that streamlines how that data can be exchanged from a payer to a provider. As an implementer, we can say that it is absolutely phenomenal. Going from ingesting member attribution data for 50, 60, 70 proprietary methods to a single method through API instead of SFTP or email or anything else, it is absolutely game-changing. So once you know who your members are, value-based care agreements are obviously bidirectional, right? You're providing care to a patient, so you have to be able to communicate back to your payer. There are a handful of implementation guides that providers can then implement to be able to send that data back. And so can payers. I see payer data exchanges on there, but essentially you have clinical data exchange or digital quality data exchange. So the two implementation guides that you can use your member attribution list, run it through your system, grab all of your quality measure data that you have part of your agreement that is included within your agreement, and then send it back to your payer so that you are, one, showing that you're providing holistic care to your member, but two, that you have that fluid data exchange mechanism within an agreement. And we have found as a provider that it's absolutely important to have that bidirectional data exchange mechanism be as smooth as possible in order to have a good idea of your performance on value-based care. So if you had asked, and apologies, I kind of combined clinical data exchange and DEQM there. I'm so sorry about that, but yeah, I did ask what were we missing at that point, right? We know what Da Vinci's already offering, and the area that we outlined as missing is this value-based care performance metrics. So that feedback loop back to providers and health systems saying, at this point in time, here is how you're measured against your agreement. Here is how your members are seen as being included. Here's how you're performing, and here are areas that you need to do additional outreach in so that you can do better. And you are on mute. So sorry.
Sorry. As you mentioned, a lot of this stems from the contracting part, and that's not in a space that we're doing a lot of at least healthcare interoperability. But what's your sense of the kind of the inputs that organizations have to understand in order to get to, which we'll talk in a moment, the kind of the data and the exchange parts of these contracts? What are they having to consider in developing the relationship?
Yeah, I think that that proprietary data exchange technology component is extremely important. Something that we've had to consider, and just to share a little bit about our current process. So when we sign an agreement, we have an internal data addendum that we share with all of our payers. And that data addendum essentially shows our partners what is the bare minimum, what bare minimum elements we need in order for the information that they share with us to be actionable. A lot of the times we hear back that our partners cannot produce that data. And so we're essentially trying to fill holes by ourselves. And so to answer your question, I would say the important thing from the start, one is to really understand your contract, understand what are the expectations on both sides, but you also have to understand your limitations, because if you are going into an agreement with the idea that you're going to get data back that is easily ingestible into a system, or that is can be easily computed by some means, and if that's not the reality, I feel like you're kind of unfortunately left in the dark. So I think providers and payers to a certain extent in general really need to have open conversations to level set what will be possible and how that exchange relationship can work.
Okay, great. So for those who are unfamiliar with the member attribution implementation guide, it really is framed originally around sharing the attribution lists for risk-based contracts, because we're you have to establish that list, and it's not static, it's changing very regularly, and that list, as I understand it, I'm not in population health, a former provider and now working in standards, it's reused over and over again for many other aspects. And so where we found the member attribution list is really going to be useful is not just for attribution, but anywhere where payers and providers have to exchange lists of patients. So it could be patients outside of risk-based contracts or value-based contracts. And one of our colleagues also from the Pacific Northwest had mentioned that they have whole rooms full of individuals who their primary activity is to manage these lists, and that the implementation of this member attribution list has really improved on efficiency. Samir, can you tell us a little bit about how member attribution has helped Providence, and where you think there are opportunities to improve on the efficiency when we start to share these contract performance reports?
Yeah, and to go a little bit a step further, so in terms of member attribution data exchange currently, I would say that most payers and providers exchange data mainly via two mechanisms. One, via secure SFTP, secure transfer protocol, and two, via email, or maybe let's add a third, portal, right? And so in all of those instances, you're essentially exchanging proprietary data. So if like Viet mentioned, that list is actionable, whether that be within your risk contract or external or part of some additional HPN agreement or but other care agreements, in order for that to be actionable, you have to do something with it. So you have to be able to ingest it in your system. You have to be able to normalize it. You have to be able to perform, specific patient matching algorithms against it to actually make sure that you are identifying your members accurately. And what happens a lot right now is that, if you, especially for a large health system, I'm sure smaller ones too, but if you have 150 value-based care agreements and you're getting 70 different formats, and the date of birth is listed in 20 different ways, and the patient's first and last name has 5 different, columns. Even so far as receiving data in Excel or CSV or TXT, having to normalize everything, it takes a lot of work. For us, it takes having a specifically dedicated development team to understand all of those agreements, to understand how the data is reflected in what we're receiving and compare it against the data dictionaries if one is shared with us. And then to understand how to incorporate it into downstream patient matching components and back into the EMR, but also into various analytic tools. We heard the last presenter talk about HPNs and CINs who are not on the same EMR. You need to have external tools in those cases that essentially allow those providers to have the data at their fingertips without having to, follow 10 different processes. And so I think in this legacy processes, I'm hoping that we'll all start calling it soon. There's a lot of room for failure. There's a lot of room for individual mistakes. And there are not very many opportunities for automation because there's so many discrepancies in the data, not just between pairs, but month to month. If something changes within a field, there's a possibility that your entire automated process fails. And so you're stuck troubleshooting that. And I think where Da Vinci's member attribution comes into place is you're using an underlying, a baseline set for your data, where every single element essentially means the same thing. And you have a normalized exchange mechanism through APIs. And it takes out all of these messy components of essentially having to go out to portals, going back and forth via email, asking why something wasn't delivered via SFTP and so forth. So it really does streamline the process, and it removes the need to have so many one-off processes to be able to ingest this data and make it actionable.
Yeah, I think I'd like to come back to one of your comments, but highlight a little bit on it. You mentioned about having to get data from other providers who are part of your contract, who may not be inside your organization. And so I wanted to highlight for folks unfamiliar, we have a couple of Da Vinci implementation guides. Actually, our payer data exchange was listed in one of the federal regulations for the patient access API, but it was really designed to help payers and providers be able to exchange payer-based data. We know that providers, they have lots of data on the care of the patients they see, and they're having ongoing care. But unless it's a closed system, they don't always know what other providers are delivering care, and even like pharmacies and minute clinics and things like that. And so the payers often, if they're financing the care, will know that information. That payer data exchange provides a mechanism to get that data back to the provider to allow for a more comprehensive view of the patient's conditions and labs and medications, so that they can take care of the patient and do good decision making. And then I'm very optimistic, and we're going through our soon to be published version of clinical data exchange, and an updated version to support lowercase a and uppercase a attachments, is the clinical data exchange, because the delivery of care requires that exchange of the data between providers, so that you can, what you're being referred for, or you're getting responses on the care that's being delivered by a specialist. But it's also going to be what we're saying is a catch-all for when payers need very specific data that may not be covered in other approaches like quality measures or in burden reduction or prior auth. And so these are a couple of IGs I wanted to highlight to kind of address what Samira said around getting data from other providers and collecting them so you can do reporting. What's your experience with that, Samira, and what are your thoughts about the opportunities there?
I have to be very transparent and say that my experience is not up there. We're in preliminary discussions surrounding this topic, so I wouldn't feel comfortable providing input that perhaps may not come to, yeah. Apologies.
And I think in context with Samira's comment, we have all these activities around TEFCA and how information is going to be exchanged. But the key thing I wanted to let the community know is that if you're in using one of the larger EHRs, you may be able to get information from other providers using the same EHR, but that we still have the challenge of getting information from the smaller EHR organizations or other EHRs. And so there's still an important role for developing standard APIs to get that data exchanged between providers, but not just the documents, right? You'll hear me talk about interoperability at different levels, but we really want to get to those data element levels as well. And as we move to talking about ultimately this use case that we're going to develop, can you talk a little bit about the Da Vinci data exchange for quality measure and how that kind of sets the stage for sharing performance metrics, and then I'll elaborate more on the technical level as well if you'd like.
Yeah, and there is one thing that I think I can say that in terms of clinically integrated networks. So I think in the way that the process currently works, outside of CDEX, CQM, is that if you are in a value-based care agreement with someone who is on a different EMR, in order for you to have some sort of inkling into the performance throughout the year, if you're not already receiving this from the payer, which there's a likelihood that you're not, you likely have to hire an external vendor who will aggregate data from both sides, store it within some sort of data warehouse or a CDW, cloud data warehouse, and then do those calculations for you and make them essentially visible to both sides. I do want to point that this is an additional cost, and not a small one by any means, a cost financially, and then a cost in hiring a vendor and having to explain all of the data mappings, the intricacies within the contract, the intricacies in terms of how your service areas are set up, or clinics or hospitals. So things that a third party is just has no way to be aware of, right, without you allocating resources. And so I think when we look at clinical data exchange, we look at DQM, we talk about TEFCA and the future of interoperability through FHIR. The underlying foundation of this is you're no longer exporting, hopefully, CCDs and then combing through that data to make it actionable and doing the calculations yourself, and then hoping that 18 months down the road, that's the same thing that's being reconciled. And so I think really the future of this, both within clinical data exchange and data exchange for quality measures, is being able to count on the fact that your underlying information is going to be in the same language, and you being able to export clinical data from multiple EMRs through that are hopefully following the US CDI framework allows you to be able to build that pool of information and make it actionable a lot easier than combing through CCDs. Whether that happens overnight, we know it won't. But I think the direction that this is going in, especially through the implementation of CDEX and attachments, is really paving the way to make this exchange more seamless and to make more of the data usable. You're on mute yet.
Sorry, I often use the metaphor around travel. We've had Expedia for like 25 years. It took a long time to get to the point where we had a large number of sites that take this common data and actually add the value of it to give you the best package. So for the vendors in Expedia, I don't think you should feel that this is a threat. It's actually going to be an opportunity to develop new, more innovative technologies to actually support the clinicians and the provider organizations to better deliver on the care, and not just spending a lot of energy transforming data to make it finally useful. And so we're hoping that that's going to support the provider community and lower their burdens. And we've learned a lot from this work in the quality measure realm, because really with the data exchange for quality measure, it built upon a number of FHIR concepts, from representing quality measures as a FHIR artifact. So you can actually represent colon cancer screening as a FHIR artifact. And those FHIR artifacts, those rules around inclusion, exclusion criteria, and the data to support it are built around FHIR data. And then we use other technologies called the clinical quality language to actually retrieve that data via FHIR, calculate that data, and then give you your metric, your numerators and denominators. And so what we've learned from that is that we have a good framework, a place to start. And are performance metrics that different? Yes, in that they're financial data often, and they might be a lot additional administrative data, but we have a good example of how we do this with clinical data. So with this next screen, maybe Samira, if you wouldn't mind talking a little bit about what are the Da Vinci members in this discovery phase are doing to kind of start to delve into what are the opportunities, the scope, and maybe tell us a little bit about the participants who are working on this.
Absolutely, and just a little bit of background again, in the way that this data exchange may work for some providers and payers currently. We talked early on about signing a contract and a data addendum and having a really solid understanding of the expectations of both sides, right? So that's extremely important, because there is no standard for it right now. That's what we're working on developing. And so in this instance, when it comes to performance data, most payers we find share data on a monthly basis, quarterly basis, yearly, or sometimes about 6 months after the performance period ends. That's not as common. But what happens is this information is shared at different venues. So it may be available during a JOC, so a Joint Operating Committee meeting. May be sent to finance folks or population health contracting folks through email. It may arrive through SFTP again. There might be a portal we have to log into to extract data. And so there really isn't any consistency there. But I think what's even more important than the way that we get the data is if you receive data in a PowerPoint, in order to be able to ingest it into some sort of database, into an analytics tool, into an EMR, there's a lot that needs to take place, right? You need to be able to extract your elements. You need to be able to make sure that you have a full understanding of what they mean. You have to tie it up to something that your physicians and executives are going to understand. You have to deliver them something that is truly actionable, that you're not asking, a group of individuals to essentially just make an inference on what you're sharing. And so right now in this legacy process, again, we have a dedicated team that is essentially responsible for understanding performance for each of these contracts. We map out all of the proprietary concepts and methodologies into something that is uniform to us. Again, it's proprietary to Providence, but uniform to us. And then we've had to create a UI essentially where some of our analysts can key in this information or try to auto import it. And then it trickles down to all of our analytics products that are physician executives and so forth, service area leads use. So it's an extremely manual process. Again, it's very difficult. I imagine that a lot of other provider groups are facing the same thing, and we have spoken to vendors as well, of course, and I think there are a lot of products out there that are, again, amazing, but they do require that either you have technical support on your end to be able to set up some of the infrastructure, or that you have user support, right? To be able to drive the process on a monthly basis or quarterly as you get the information, or you're paying for that support. So I think the ideal way that this can kind of go down the road is you have, as Yet mentioned, kind of based on the CQL and the quality components, you have a standard set of measures tied to financial and pseudo quality financial performance. Not performance. Let's call it something other than performance, but that's kind of what it is. And you're able to exchange data seamlessly. Where again, taking it back to member attribution, your element has an expected value. Your provider knows that what they're receiving is adhering to, this standard, and all of the data that you get is some sort of profile or version of that standard. And so. Not to negate what's on the screen, I think it'll kind of help paint a picture, but some of the basic things, and this is extremely simplified, but some of the basic things that you might receive in these instances is, the contract name. This says Humana because when we presented this initially, it was in partnership with Humana, so thank you to the Humana team. But you would have a contract name, you would have a contract key. It's very important if you're going to be writing code to have actual keys. You have your participating entity. This would be reflective of who is actually contractually participating. It might be a clinic. If any of you are familiar with Primary Care First or CPC Plus, that's kind of how that's structured. It might be a hospital for inpatient programs. It might be a service area, so a larger geographic area that's participating, or it might be your entire health system, right? So whatever the participating entity is, that's what would be listed. And then some basic elements, I would call them. So something like total premium, and there could be variations of premium. So total dollars earned for the contract, or whatever is funding the contract. Total spend, so this is going to be through claims, durable medical equipment, any of the categories, RX, whatever is contractually included. Your medical loss ratio, so the difference between what you're earning and the spend. Your quality scores, so if by chance your contract is gated, meaning that you as a provider cannot share in any of the my gosh, the shared earnings until you meet a quality score proving that the care that you're providing is focused on quality and not just on, you know, billing as many services as you can. And then your shared savings component, which is usually split between the payer and provider. Then at the end somewhere you would have a piece that says, you know, here are your financial earnings. It might be split up by quality or shared savings or any of the categories that are included. Again, this is very, very overly simplified, but these are just some examples of the things that we can expect to be exchanged. And right now what we see is that, you know, there might be 5 different variations of total spend, or what it might be called something else. And so it would be ideal if we as an industry came together to come up with a standard or set of standards for what total spend would actually mean.
Yeah, and I think your that last point I'd like to highlight, because I made a couple of notes, is when does a community come together and say it's time to make a standard? And I think if we look at the days, none of us were alive during the 1800s, but the 1800s and railroad tracks. Railroads were getting more and more common. The gauge of the tracks, the distance between the tracks were varied across the country. And it got to the point where we needed to ship things across the country and we had to agree on a gauge. And so there are a couple of components that this use case and the others we mentioned really exemplify when are we ready for a standard. One is that it's a common workflow and practice. All of you who are doing value-based care probably do some version of this. And many of you who are participating in CMMI programs are probably already doing a lot of this for CMS. Samir pointed out how costly it is to put out RFPs, find vendors, implement. It's that the vendors don't always do all the implementation. You have to have capabilities within your organization. And then depending on how well you like the platform, or if there are new innovative things, the cost of changing. The inefficiency of the current processes to get information in so that you can leverage that information to improve care or improve efficiency. And it's slow. I think what we're learning is that we always say data has to be actionable. And I can't imagine if 6 months you're getting data from 6 months old, you can do a whole lot to improve your performance. You may some, but the more timely and accurate that data is, the more of an opportunity you are to improve it. And so I often tell people, like, it's like if you never got a progress report on how you're doing in a class and all you get is the final exam and the score, that's a bit problematic. So this is a really great opportunity. But as we go through this process with our members and sharing with the community, we're really trying to figure out what is going to be in scope and not in scope. And so we maybe Samira, if you wouldn't mind, it's kind of high level or anywhere you want to focus, highlight some of the things that you think are good opportunities to keep in scope. And I did want to mention that, you know, we have providers like Samira and others. We have payers. We also have Da Vinci vendor members, and we have CMS and CMMI there listening in and also, you know, providing some their experience in this, because we know that if we don't develop specifications and standards that will work for the community with their input, then it becomes a new burden. And so part of our goal is to really get that feedback. So I'll hand it over to Samir if you'd like to talk a little bit about what would go into some of these things in that kind of next level of detail.
Sure, absolutely. Yes. And I have to second what you just said. I think it's so important that this work for everybody, not just for providers. It's payers that are producing the data. It's vendors that are stepping in to help alleviate the burden for the providers. And so the more representation that we have across the board, the better it is for all of us. And in terms of these categories, so they're pretty general, right? We want to keep this pretty high level for right now to determine scope. But some of your basics are contract details. We talked about the importance of this in the beginning. If you don't understand all the individual components of your contract, it's really difficult to take into account anything else that is shared. So most value-based care agreements go from January through December. Sometimes you have agreements that run mid-year to mid-year. You may be in an introductory period with a payer and you sign up for kind of a pre-agreement for a quarter to see how this is going to work. So all those things are important to have detailed out so that, one, you understand what you're being measured against, What are the parameters and so forth? Who is participating? Are your HPNs or CINs also responsible for part of this? So all of that. Your population pool funding, what does that look like? Where is the money coming from? Are there any discrepancies that you have to take into account? Are there any carve-outs that are specific to your partnership? And then what are expenditures? What do they look like? In some instances, you might be receiving a care coordination fee to help with clinic practice, or to help provide after hours care, or to build out additional components. And that might be an expense. So it's important to understand how everything is being allocated. What actually goes into total spend? What are you going to be held against at the end? And there's a lot of categories with that. Is quality a component of your agreement? If so, is it because that agreement is based solely on quality, and you're submitting data to essentially just show that you are doing all these preventative exams, that you're providing upstream care to your patients, that you're doing outreach, all of that stuff? Or is it gated? Does how you perform on quality influence whether you have an opportunity to generate shared savings? So that's really important. And then what does earnings look like? And I think where this gets really exciting is over time, you'll have enough data to essentially see how changes that you've made in your outreach, in your patient care, in community things, social determinants of health, whatever it may be, how they've been able to impact your value-based care agreements. And so I think within the earnings category, we should be able to focus on what's happened in the past. We should be able to focus on the present. So where are you at this point in time within your agreement? But we should also look at things like what's your earnings potential? If you do absolutely everything to your contractual terms, you're providing all the services, your physicians are very actively involved in this, what is the best outcome for both the payer and provider side? Because you obviously still need to be able to generate revenue to keep your doors open, right? And so I think these are just some of the categories that allow you to paint a picture of how healthy your population is, how financially healthy you are, areas that you need to focus on, perhaps for outreach and so forth. So I'm sure this can expand to a lot more, but that was the initial take.
Yeah, thank you for that. Coming from a clinical background, interoperability, I'm very comfortable with the clinical concepts and data elements, but I'm learning a lot about all these new concepts. And I imagine we have folks in the audience who are providers who haven't reached that kind of threshold of that value-based care is a significant part of their the revenue. But I'm imagining we're going to do a lot of level setting on our terms and making sure that we're agreeing on what they mean and how important they are in order to standardize on them. But I think this is a great opportunity. And so with that, I wanted to share a little bit with the community where we are. So as I mentioned, Deepak from Providence is on our steering committee, introduced the use case. We got good buy-in for it. We're now doing the member discovery, which is really just a short period where we're trying to figure out what's the big picture and what we think is a reasonable scope. And what we look to do in the next couple of months is actually to take this to the public forum. And so Da Vinci, as a HL7 Fire Accelerator, will be putting in a project scope statement, taking it through the HL7 process, I'll say, where ultimately it's an implementation guide. And there's a lot of activity between that second and third box. And that's where the opportunity for the Wedi and broader community to come join us. I recognize a whole bunch of names on the participant list today who've been in our calls, and we welcome your input, because the first phase of this is not the technical aspects. It's the really making sure that we have common terms, common business requirements. Do we understand the workflow? Do we understand the opportunities and when we need to do this exchange? What are the data requirements that we need in doing that exchange? And at what depth do we go to standardization? Does it the algorithms? Is it we can already represent patients, but do we want to do patient level data? So these are the kind of things that depending on the ability to do that, the challenge and the time, we can start to decide that. And then we'll start to develop the fire aspects of it and start doing testing and connect-a-thons and ultimately put out a ballot. I think we are optimistic that maybe somewhere in the springtime of next year, we'll have gone through this work in depth enough to get to an implementation guide. But ultimately, we need your participation in order to make really good guides and to test them out. But along the way, you might be asking, well, how do I participate? How do we even get going? So I'd like to ask Samira, like, what was the journey that Providence had, and who did you have to bring into the journey and develop what I've been calling kind of a cultural competence around interoperability? And can you help the audience see where they can bring in others in their organization to promote this and to make this happen for them?
Is it safe to say everybody?
Yeah.
We really did take a centralized interoperability approach. I think early on, we acknowledged that even though value-based care is very population health driven, we couldn't do any of this alone. I heard the topic of prior authorization mentioned previously. That is very revenue cycle driven. And so we know that there is overlap between revenue cycle, billing, claims, registration, care, privacy, legal, and so what we did is we created a interoperability committee that meets at least once a month. And that interoperability committee consists of population health, it consists of risk and compliance, it consists of government affairs, our EMR counterparts, so our EMR leadership internally. I mentioned legal, our value-based care account management team, contracting, just a ton of people. And our goal through that is to be as transparent as possible. In those sessions, we're able to say, okay, we acknowledge that we have these agreements. Here's the direction that we need to go in, and here's the help that we need to get there. TEFCA was brought up early on. We've been following that for a while. And so we talk about every single step of potential participation, of build, of, what does it mean to exchange clinical data through an implementation guide through Da Vinci? And then each of those teams essentially brings their subject matter experts to the table to be able to help us accomplish this. And so what we've really found over the past, I want to say almost 3 years, is that really, you need to have people who are experts in their domains participate. You need to be able to have them push back because, again, they're experts in what they're looking at. And you need to be open to that conversation to be able to sometimes say, hey, perhaps this isn't the direction that we want to go in, but let's collectively decide on the next steps and let's figure out how to achieve this. Without doing that, I think it's, it kind of, without having that collaboration at such a high level and then going to the technical framework, you're essentially still building things in silos and you risk having other teams duplicate efforts and so forth. So I was partially joking when I said everybody in the beginning, but there really is a lot of involvement on this, and rightfully so, because we want to make sure that all the right people are at the table making the decisions.
I agree with you. It is everybody, in my opinion, because in the same way, everyone in a healthcare organization needs to understand privacy, safety, security. Their role in interoperability, either as a data creator or a data consumer, is important. They don't have to, I'm confident in saying they don't all have to know about fire, but they, in the same way, we all need clean water. We know that that's important. So we're all done with this last slide. I just want to suggest folks join us at confluence.hl7.org, at Da Vinci's website. You can find lots of information, a lot of information about our use cases, and sign up for our listserv, where we'll be announcing when we go to public meetings on this value-based care work. And if you have any questions, please feel free to reach out to me or to our program management. And thank you, Samira. This was really great, and I hope the audience gained some new insights on what we're doing. And I'll hand it back to you, Michael.
Thank you. Thank you very much, Dr. Nguyen and Samira Singh. Very informative. I'm really excited about the new IGs coming out. And I've just recently joined your group, so looking forward to more. Michael, I'll turn it over to you for the next session.
Appreciate that, Michael. To propel value-based care to higher standards, the need of the hour is to compose a comprehensive portrayal of health outcomes, which means the inclusion of social determinants of health, SDOH. We're delighted to welcome Arjun Gosain and Samir Farouk of Arcadia to discuss their research, which highlights that SDOH are driving medical expenses and poor health outcomes. Their predictive models that are optimized against value-based care have shown very strong sensitivity to SDOH factors. Arjun, Samir, welcome to the spotlight. The floor is yours.
Thank you, Michael. Could you please make Samir the co-host as well?
Just did.
All right, thank you.
All right, thank you all for coming. Give me a second while I get my screen up. Let's see. Thank you, Michael, for the introduction. Really appreciate it. So, yeah, I mean, again, we thank you for joining us this afternoon. We welcome you all from Arcadia here in Boston. We're really excited to talk about social determinants of health and how it plays a role in value-based care. And really, we hope to immerse ourselves, both ourselves and you, in this conversation as we discuss more, about our research, which is a part of a leading frontier creating value through SDOH. And while we'll try to keep ourselves targeted and focused in this discussion, but I hope you'll forgive us if we get a little bit technical and into the weeds, because our research has, it's kind of led us into some rabbit holes and such. And we want to share that with you, and hopefully that'll be part of the immersion process as we show, what exactly is the capacity of social determinants of health and what can it potentially offer, in terms of value-based care. So I'll introduce myself again. So I'm Samir Farouk. I'm a senior data scientist at Arcadia. I graduated from the University of Rochester Medical Center, where I was born and raised, actually in Rochester, about 6 years ago. And then I was hired immediately on into the medical center, where I was really particularly in HIV, studying HIV patients and showing how we could use novel techniques and data science to get value-based care for our HIV patients. And then since I was there for 2 years, and then since then I've been at Arcadia.
Court 3, the tennis court at 6.
Sorry, what was that?
Just a little technical difficulty there, Samir. Please continue.
Okay, great. And so, and that's basically my story. So I'll hand it off to Arjun, who will introduce himself, and then he'll get us started with the proceedings.
Thanks, Samir. Good afternoon, everyone. I'm Arjun Gosain. I'm a senior data analyst for Arcadia.
Arjun, you're on mute.
Good afternoon, everyone.
Oh, okay, there you go.
Can you guys hear me now? Can you guys hear me okay right now?
Can you guys hear Arjun?
It's a little softer than yours.
Okay, there you go. We're in the same room. We're sitting right next to each other.
So yeah, sorry about that. Good afternoon, everyone. I'm Arjun Gosain. I'm the senior data analyst at Arcadia. I graduated with my master's in management information systems in 2016, and in working in healthcare ever since. I started my career as a data scientist in population health for a health plan in Michigan for 3 years, where I focused on care management, workflows, risk stratification, and SDOH, and transitioned over to my current role as a senior data analyst for customer insights for our organization, working directly with ACOs, hospitals, health plans, working identifying problems and providing solutions using data and analytics. I just want to thank Wedi for inviting us to this conference, and I'm happy and very excited to share our results about a topic that I personally feel very passionate about. So with that, we'll just get right into it. So Before we start and get into our research and analysis, I just want to dive into what SDOH really means and why is it an important issue in healthcare today that we need to address, and what are some of the challenges that the industry is facing at the moment when it comes to handling SDOH data and strategy. So SDOH is basically conditions in the environment in which people are born, live, learn, work, eat, pray, and age that affect a person's health, well-being, and quality of life outcomes. Research shows us that traditional model of healthcare delivery that involves hospitalizations, encounters, pharmaceuticals, and procedures only account for 10 to 20% of a patient's health outcomes. A majority of health outcomes are outside of direct provider control and are determined by individual behaviors, attitudes, and social and environmental factors. SDOH, or social determinants of health, also contributes to health disparity and inequities, and therefore minority populations tend to be affected by them disproportionately. So because of all these reasons, SDOH is an imperative issue to address in healthcare today in order to achieve health equity and also improve healthcare outcomes for our patients. Talking about SDOH for examples, these can be categorized into different domains. As you can see on the screen, SDOH factors may include housing insecurity or difficulty to access food. It also involves economic, employment, and instability. It can also affect access to care due to lack of transportation. Or SDOH also covers more personal conditions like upbringing issues, living alone, or childhood abuse, or being victim of a war or other hostilities along the way. So these are just some of the examples of social determinants of health and why it is important in healthcare today. Going along, what are the common challenges that we face today around SDOH? As I mentioned, like health plans and ACOs understand and accept that SDOH is driving medical costs and poor health outcomes today. But a lack of data really makes it very difficult to define a comprehensive SDOH strategy. Organizations are typically involved in a vicious cycle of three major factors that start with identifying the right patients. So curating data for patients with social concerns is a little tricky and not very straightforward. ICD coding is limited, and people don't always reveal their social concerns right out of the way. Because identifying patients is an issue right off the bat, defining impact without proper identification makes it a little more difficult to really calculate impact of SDOH on a particular population. And because defining impact is a challenge, it eventually stems down to organizations having difficulty in justifying a financial investment into a robust SDOH strategy. So organizations are always stuck in this vicious cycle of these three challenging factors. And we're going to look at some examples of how we can try to address these challenges and what are we doing currently in our research. So as I mentioned, identification of patients is primary and the main issue, pain point right now. One way to address that issue is to find robust approaches for SDOH data capture. Following technology advancements of today and like federal mandates, it has become, we have access and we have the ability to capture data right at clinical sources from EMRs and other clinical data systems. We can capture SDOH data right straight from the point of care through structured assessments. We also have the ability to design our own patient-level SDOH-specific surveys, perform patient outreach campaigns, text message campaigns to really capture more patient-level identification when available. The second source of data is ICD codes that we've already discussed through EMRs and claims as well. And as SDOH gains more traction along the way, we are seeing an immense improvement in coding strategies around ICD codes as well. Apart from these two patient level identification, we also have data around on the census block level, which is also important and important data source to understand neighborhoods around a patient's workplace or home address, along with these patient level identifications of surveys, assessments, and ICD codes. Census data can become very impactful in identifying the right patients. And if, lastly, all three also tie into predictive analytic strategies. So once we have enough data available, we can create algorithms to really identify patients of highly likelihood of SDOH concern. Granted, there are certain caveats and certain difficulties in using each of these data sources by itself, but when used in tandem together, these can be really impactful in really identifying the right patients with social concerns. So moving along, that once we have defined our strategy to really capture more data and really get better at identifying patients with social concerns, we can try to attempt defining impact of SDOH on our populations. Our initial research and work with a couple of non-for-profit health plans in the Pacific Northwest resulted in some very staggering health outcomes. Chronic condition prevalence seemed to be one of the major factors, differentiating factors between your SDOH population and your non-SDOH population. As you can see on your screen, the numbers are really staggering around diabetes prevalence. So diabetes was prevalent, diabetes prevalence was at 24% in your economic insecure populations compared to your non-SDOH populations where it was at 7.5%. Similarly, for COPD, prevalence of COPD in a housing insecure population was at 21%, while it was down to 4.4% for your non-SDOH population. Those are some very major differences between your SDOH and your non-SDOH population. Furthermore, talking about value-based care, patients with social concerns also had a major effect on cost and utilization metrics. Some of our observations highlighted that members with SDOH concerns were twice as more likely to get readmitted within 30 days compared to people without SDOH concerns. Furthermore, members with housing insecurity tend to visit the ER 5 more times in a calendar year compared to people without that concern. And lastly, members with social adversity have 6 times more higher PMPM than those without. So these were some amazing health outcomes that really drove our research and analysis around SDOH and really made us look further into why SDOH is an important issue and what we can do further to really address this issue in healthcare today. So with that, I'll head it over to Samir, who will go into a much more in-depth analysis around our predictive work of SDOH and discuss our outcomes out of that project. So over to you, Samir.
All right, thank you, Arjun. So I'm going to be tackling a little bit of a different approach, and so that's because Arjun's on the insights team and myself, I'm on the data science team, and so we tackled this problem about we first had this problem about 3 years ago where we saw that okay, we're trying to find how can we optimize value-based care for complex case management patients and behavioral health patients. And we quickly understood that we needed a way to get social determinants of health information, which was really lacking at the time. And so as Arjun pointed out, one of the best ways to get that information is assessments. 3 years ago, we didn't have that capability, and so we were left with the next best way, which was using ICD-Z codes. And so we really hooked onto that. And at first we were only using housing insecurity, but then we gravitated and used a bit more reliable, other factors that were reliable based on their coding nature. Of course, we wanted to include more, but these were the 6 that we basically concluded on or converged on, is because their coding was enough where we were confident that we can use them in our modeling. So education risk, job insecurity, housing insecurity, living alone, upbringing issues. Social disruption is the only real different one from what Arjun mentioned before. which is really a combination of social adversity and also a lack of support at home. And so we wanted to see, the first question was, okay, is how prevalent is this from among the two different populations? So in the complex case, the first thing you'll notice is that behavioral health patients tend to have a greater level of prevalence than complex case management patients in every factor except for two, which is I think it was living alone, and social disruptions, which is interesting. I want you to keep those in mind as we go forward in this presentation. We'll show you some interesting analysis that has come from that. But also, which was really interesting, is that there was almost 3 to 6 times more prevalence in behavioral health patients than complex patients in these factors, which we definitely suspected a greater level in the behavioral health patients, but we didn't expect to that degree. So the first thing we wanted to do is we wanted to put the complex patients under our microscope. We want to see, okay, which one of these factors is the most strongly associated with high outcomes, and so, or high, in this case, we're calling them high risk. And so we defined it in 3 different dimensions. The first dimension was medical costs, and then avoidable ED visits and unplanned inpatient visits. And what we're really trying to do is we were trying to predict how likely is it that a patient will have high costs or high any one of these outcomes. And so the first step we took was to create a threshold that defines what high cost is. And so in this case, we kind of decided on, if you're age 65 or older, then a threshold of $1,000 PMPM seemed about right to be high cost. Anything above that, otherwise above $500 PMPM. Avoidable ED visits, we chose a threshold 2+ avoidable ED visits and 1+ unplanned inpatient for inpatient visits. And this was in a span, this was in a window of 12 months to get you, a sense of control in terms of, what exactly is high number of visits here. And so the interesting thing we found is, so we compared against, your control, which is what if you had no SDOH. And then the green bars, what if you had SDOH, or what is the probability of that high risk in each of these categories? And there was really only 2 that we found in this case that were really strongly associated with all 3 outcomes, which was housing insecurity and living alone, which was interesting, but also it's humbling by the fact that, it's not necessarily the case that all of these factors will always, at all times be strongly associated with the outcomes that we're looking at. And you can expect that, some of them will not likely offer as much, novel information than using other factors that are outside the realm of SDOH. But also, I want you to keep this social disruptions in mind, which is almost equal between the non-SDOH and SDOH. I really want you to keep that in mind because we're going to be talking a little bit more about that in a second. So we also wanted to look at, what is it like for the behavioral health patients? And we really found something different. And by the way, the only outcome that really changed here is instead of using medical costs as an outcome, we gravitate towards using med adherence risk as an outcome. So you kind of have to think about it inversely. High med adherence risk translates into low med adherence. And so we were just trying to keep so it might be a little confusing, but when we're talking about, having a strong association with the risk would mean, a strong association with the low med adherence. And so the first thing we found was that almost all of these factors were strongly associated with these the probabilities of high risk. With really the only exception being education risk, and that too. It seems like, there's, for some reason, patients who, have, they might be illiterate, or they might have trouble having access to, they might have trouble getting access to a college degree or even a high school degree for that matter. They might have difficulty in that. But and that shows potentially a risk of lower med adherence with the third bar. But the interesting thing is that it doesn't necessarily translate into the utilization. Where we kind of find, either an equal or an opposite effect, where the likelihood that you have high ED visits or high unplanned inpatient visits is not necessarily as high. In fact, perhaps even lower, which is really interesting. That's something that stood out to us. Okay, so the next thing we want to do, and this is where it starts to get a little technical and into the weeds of stuff. And I'm gonna try to be as brief as possible. So let me introduce, what we're basically looking at. So we have two different cohorts that we're placing under the microscope here. Again, the complex patients and the behavioral health patients. And for each, we show the outcomes that we're trying to find the association of. And what essentially these figures shows is an algorithm that was designed to rank feature importance, going from top to bottom, being most important to least important in predictability of future outcomes. And so there are a few different points that we kind of concluded from these slides. And so the first one was that you can't really treat all the outcomes and contexts the same. And this is really what I think Arjun kind of alluded to this before. But also we alluded to this a short while ago, which is the fact that, as you look at these, as you look at this figure, it seems as though it kind of varies, what rank these factors are going to have. And in fact, the factor themselves rank differently depending on even the cohort. For example, if you look at the unplanned inpatient for both cohorts, you would potentially expect similar ranking, but actually it seems like in this case social disruption and housing insecurity kind of got flipped, but then the rankings kind of got jumbled up afterwards. The right three bars, by the way, I didn't mention. You might notice that the left three bars, they go from rank from 0% to 100%, and the right three bars go from 0% to 70%. That's because that's just a result of the algorithm. Because when we're evaluating the behavioral health patients, we had many more features going into them, and so the algorithm is has a high time complexity, and so we asked it to ignore anything that was statistically insignificant, and so that happened to be around 32% of the features that we're using. And so we had a giant pool of features, and then 32% of that was just ignored in this whole process. And then ranking was done afterwards. Whereas, and that probably saved us around 2 days of just processing time, because the algorithm does take a while for it to run. But anyways, that was a caveat. The second point, or the second thing that we noticed, was that for the complex case management, folks, we found that social disruption was almost always consistently the highest ranked of the 6 social determinants of health. And interestingly, this alludes to the idea that patients who lack support at home, maybe there was a divorce, or maybe I'm forgetting the other context of lack of support, but there are other things within the family issues that causing stress at home, and that is causing the disruption in their social life. It could also be racial segregation and other things like that, and it seems to have the strongest effect most consistently across outcomes when we're talking about complex case patients. And it's not necessarily found in the behavioral health, although it is kind of strong as well in some of these utilization factors. When we move over to the behavioral health patients, we found that the most consistent was upbringing issues. And so, upbringing issues include an entire spectrum of things. Like it could be something minute as, too much parental control, or well, it's minute depending on who you ask, but parental control, and it could be a bit more it could be on the other side of the spectrum as well, like hostility towards the child, or even child abuse, even above that. And so it seems as though those type of factors seem to have the strongest leading association to predicting these outcomes for behavioral health patients, where it wasn't as strong in the complex context. And so when we look at all these diagrams, the one that illuminated to us the most was the medical costs under the complex patients, because this was the only one where really almost all 6 social determinants of health, in this case 5 of them were really at the top, and it seemed to be really important in predicting what your medical costs are going to be in the next 12 months. Interestingly enough, when we look at that from amongst them, and I think it leads to the next point, education risk was actually, if I can go back, let's see, education risk, when we look at this analysis, it seems as though under medical costs, they have a negative association when we look at the SDOH factor under high medical costs. Whereas in this, we find that it is the top ranked feature. And so basically, what the outcome is here is that, or the conclusion here is that not only are they the positively associated features relevant, but also negatively associated features are strongly relevant as well when we're trying to predict medical costs, because it increased specificity of the model. If you can, not only are we trying to identify patients who are likely at high cost risk, but also we're trying to weed out patients who will likely have lower cost risk. And so if we are to do that more successfully, then the patients that we're really choosing for high risk are going to have a stronger specificity. And so when we look at these, we have to look at it at both angles, that there's a positive association with high risk, which is a good thing, but also if we can find that there's a strong negative association, that is also, there's also a lot of power to that concept, and that it allows, in this case, our model or predictable models to perform more strongly. And those are, so I want to then get into a different dimension of this whole thing, and I'll have to introduce a little bit our impact score and what it is. Essentially, our impact score is we try to rank patients on those who will likely benefit from care management, but also they're in need of care management. So we're trying to optimize both high risk and they'll likely see benefit from the management. When we apply, so the first thing we did was that we fed in our SDOH models, and we said, okay, 0, 1, if you had a SDOH factor present, then you feed that information to the model as a binary factor. But we were a little concerned, because when we do that, that means a factor that occurred 3 years ago. Let's say we found a housing insecurity flag 3 years ago. That means a patient who was flagged 3 years ago would be treated the same as a patient who was flagged a few days ago. And we wanted to see what would happen if we kind of tweaked the algorithm here a little bit, where we added a recency weight measure, whereas such that things that occurred more recently had a higher weight in our algorithm. And so our previous thing was, let's say we have this entire population, and the impact score is designed to select 10% of your patients. And so impact score V21 was time agnostic, whereas in V22 we added this time dependency into our SDOH, and actually other utilization metrics as well, like ED visits and all that stuff. So the concept is the same. The impact score wants to select the patients who are the likely, those who will likely see benefit and risk, but they might disagree now in terms of who we're selecting. And so what we wanted to know is that, okay, well, there's definitely a strong area where they both agree, but why are they disagreeing? And so where they both agreed So the bottom half of this table is kind of summarized where they both agree, and it seems as though high prior costs, high morbidity risks, their demographic risk, and other utilization stuff, like, if you had stronger PCP visits, or if you had lower PCP visits, you would likely be more impractical because there's more engagement you could do for those patients. The potential, and basically, potential energy is very high when you have low engagement. Whereas when we looked at, where they differed, we found that what we really were finding were the SDOH factors, and almost all 6. And I think these are the 5 of them are really important in terms of why version 2.2, which is more time sensitive, was choosing different patients. And so it found that, if your patient was to have, more recent job insecurity issues, upbringing issue, living alone, or social disruption, there was a higher level of indication that these patients are going to be more impactable than if we had looked at them under V2.1, where they were just flagged 0.1. With the only exception being housing insecurity, interesting enough, which almost suggests that that's almost time insensitive. In the sense that, if you're housing insecure 2 years ago, that should probably be, according to the model, you should probably treat them the same under the complex case management context. Of course, it changes depending on the context, but what we really found is that, adding these time weights was really important when we're, trying to deliver value-based care to the patients. And I just want to close off with the 3 different things that, we'll conclude from this presentation was, the SDOH remains a challenging topic for the 3 issues that Arjun identified earlier. Identify patients, defining impact, justifying financial means, that whole cycle of things makes it very difficult. And also when choosing, another point that we want to conclude on is that when we're choosing factors for value-based care, we have to include SDOH. Because both strong positive association and negative association are both important when we're trying to find patients who are the best for value-based care. And it could be because they show the greatest value in medical expense, so poor health outcomes and high utilization. And if the last point is that if an SDOH factor is disassociated with the outcomes, at least in isolation just by itself, that doesn't necessarily mean that the SDOH factor is not meaningful, because it can still be meaningful in 3 other ways, which is in the combination of other conditions and factors. But it could also be meaningful when you numerically transform it, as, for example, how we applied the time weighting factor. There might be an opportunity to apply other transformations as well that might make the SDOH factor more useful. And then also, just because an SDOH factor seems disassociated in one context, for example, maybe it's disassociated in the context of behavioral health, but that doesn't mean that in the context of complex case management or a different context, like for transition of care or a different context entirely, that they might not be extraordinarily useful in our conversation. And that's essentially how we would like to close off. And so again, we really thank you guys for allowing us to present this information, and any questions, now is the time. Very, very valuable.
Excellent. Samir, Arjun, thank you very much. Oh, there's a little bit of echo coming from your mics. Real quick question that's popped up on the chat. And anyone else who has questions for Arjun and Samir, please fill them in the chat. What tools or conditions would make it easier to get more specific person-level data on SDOH directly from the individuals? How are social factor data otherwise captured, whether from assessments or Z codes, intake, point of care, billing, etc.? Who uses risk impact scores generated by Arcadia?
Yeah, I can take the first part of the question on what tools or conditions would make it easier to get SDOH data. As we mentioned, we have the ability to take in right from the point of care. We have standardized SDOH assessments out there, like prepare surveys, for example, that really ask questions on a person level while a person is new to a health plan or doing an initial HRA assessment as part of their SDOH questions on those assessments as well. which we can really curate and map towards to one of those specific SDOH factors that we mentioned earlier, and really make identifying patients a lot more easier on a person level. How are they captured? We use different methodologies. We take it right at the point of care through prepare service that are coming from EHRs. We also look at Z codes that are built as well. So we use a combination of all data sources and trying to capture as much identification through these specific sources as well. And some of the tools that make it easier is, like I mentioned around, we have the capability to do some patient outreach campaigns or text messaging campaigns where we actually send out questionnaires or surveys right through a text message to members directly to have them answer questions that are related to social factors and capture that data and map those answers to those questions to specific SDOH terms. For risk impact scores,
yeah, I can speak briefly about that. So we have several clients that are really interested in the impact score for a few different reasons. The initial reason is really for value-based care because they have a bunch of resources, a bunch of for example, let's say you have 25 care managers or nurse practitioners who are used to assign a patient whether or not they'll be useful in care management. The problem is that their workload is immense because every care manager, they might need to go sift through potentially hundreds if not thousands of patients to best identify who will likely who should we allocate our resources to, because the resources are limited and unfortunately they can't target everyone. And so we want to know not only are those who are in need, but those who will actually show benefit. And sometimes a patient might be in high need, but they might be elderly and they might have high complications and all those things, and that leads to not really a whole lot that care manager, if they're assigned to them, that that they can do to improve their condition. So it's really for those who are looking to optimize and best utilize the resources they have. And the risk score is that's an impact score. The risk score is a different dimension. It more alludes to the level of risk, like for example, if the level of condition risk that a patient might have, or what the one that is most used from Arcadia is a readmission score, which is what is the likelihood that a patient will be readmitted in the next 30 days. And we played around with it doesn't matter if the event before is agnostic. In other words, if you were discharged with let me think of an example. Let's say CHF, congestive heart failure. If you're discharged with congestive heart failure, what is the likelihood of readmission? Does that play a role in the probability that you'll be readmitted in future? And also, what about things that are more specific to the event itself? What happened during the hospitalization, and how does that relevant to being readmitted in the next 30 days and things like that? So those are the type of risk scores that that our clients are interested in. But the most popular, of course, is the impact score, because that's the one where we're trying to optimize the use of the resources that are just limited at the facilities.
Excellent. Thank you very much. It doesn't look like we have any additional questions. Feel free to stick around, though. People might be asking through the chat. Samir, Arjun from Arcadia, thank you very much for being a part of our value-based care spotlight today.
Thank you.
Thank you.
Excellent. I'm going to hand it back off to Michael Patwell, who is moderating our final session of the day.
Great. Thank you, Michael. So this final session will elaborate on the work many organizations are driving to bring us to the crossroads of value-based care and interoperability. Often I speak of the work Wedi, Da Vinci, CAQH, and others are doing to drive us to this crossroads. The genesis for this session was an article I had published in HIT Consultant a few months ago. So without any stall, I hope everybody's ready. I'd like to introduce our speakers one by one, allow them to tell a bit about the work they're doing in value-based care. Erin Weber, are you on?
I'm here, Michael.
Sweet. So you just want to give us a little introduction, what you do for CAQH?
Sure, absolutely. I'm Erin Weber. I'm Vice President of CAQH Core. I have been with the organization for more than 12 years now and have a background in revenue cycle consulting, working with both the advisory board company and the Veterans Health Administration at PwC before I joined CAQH. And in my role at CAQH, I lead all of our rule development efforts, our education and outreach programs, as well as our participant relations and policy work. In particular, I led some value-based payment work we launched in 2018 that I'm going to share a bit of an update about later today. So that's my background. Thanks so much for including CAQH Core in today's panel.
Thank you, Erin. You're our closer. Michael Phillips.
My name is
Michael
Phillips. I'm a manager on the CAQH core team, assisting with operating rule development, as Erin previously mentioned. I joined the team about 4 months ago and coming on as a value-based care or payment subject matter expert of sorts. So building on the work that Erin mentioned that was begun by CAQH Core several years ago, we're taking that work into new steps, new areas in order to understand what the current obstacles are and what the current trends are to adoption and implementation of value-based payment models. So I'm very excited to be here today and to share my insights. So thank you very much, Michael.
Thank you, Michael, and glad to hear that you're here with CAQH and looking forward to hearing about what CAQH is doing coming up. And lastly, we've already heard from Linda Rowe, but Linda, do you want to just reintroduce yourself?
Sure. Hi, everyone. I'm Linda Rowe, Senior Advisor of Value-Based Markets at InterSystems, our sponsor today. I spent a lot of my time actually doing research and understanding what's happening in the market vis-a-vis value-based care. So talking to customers, prospects, industry experts, because you can't figure out where you need to go if you don't know where the road is going. So I like to think of myself as a person that tries to figure out where is the puck going. So thanks for having me today, Michael. Really appreciate joining my two colleagues on this panel.
Thank you, Linda. The roads are going to the crossroads here. So thank you, Erin, Michael, and Linda for joining us this afternoon. And a really big thank you to everyone still with us at this end. Really hope and I believe you will see and learn something new about how certain organizations, I kind of call CAQH a silent superhero, probably too much, but I really do believe they are really doing a lot of great work behind the scenes, and really looking forward to hearing from Erin and Michael on that end. But I think I'm going to start with Linda from InterSystems. Linda, and please have Michael advance your slides when you want. But Linda, could you give us some insights and trends that you're seeing out in the field? In your opinion, how far are we from the crossroads of interoperability?
Yeah. Interesting question. So if you can move to my first slide, I'll start here. So I love to read, articles, journal articles, what's going on. And so New England Journal of Medicine has a piece, a journal that they call The Catalyst. And they did a survey of a number of healthcare organizations. And the question they posed is, how aligned are you clinicians with your payer partners in moving to value-based care? So where are you at? And 77% said, we're not aligned at all to achieve value-based care delivery. And 58% said our own organization isn't even ready. So, forget about having partners. We just haven't got our own selves organized. And only 3% said that their payer and provider partners were aligned or extremely aligned. So if you think about this on a 5-point scale and you count the 4s and the 5s, only 3% were in that bucket. So, here's the problem, right? If we're really not ready and not aligned, that's hampering the integration of care, and it's driving some of the, the higher cost and the fee for service sort of cycle we're on right now. So if you go to the next slide. So in that same article, they asked, where are you most aligned and where are you least aligned? And they gave them a whole list of things to choose from. And they were most aligned on sharing data and doing quality measures. But even then, it's 58%. They were least aligned on data sharing for decision making. So I'm sure many folks on this call are not surprised by that number, but that's pretty low. So if you go to the third slide, sort of from the same survey, this is just the same data, but if you look at the light blue, sort of the first two, the very light blue and the moderately light blue, that's the not aligned stuff. So at the very top, look how much there's light blue there in terms of, not aligned. And when I talked about, the extremely and very aligned, right, for data sharing, that's a pretty small, it's like 10%. Quality measures is doing a bit better, but still, at the time of the survey, the journey was still, looking like not the light at the end of the tunnel. So if you move to my next set of thoughts. So earlier today, our first speaker talked about the land survey and the great work that the Land Network has been doing to measure this. And she talked about the different categories of alternative payment models, value-based care, sort of how we bucket them. So there was category 1, 2, and 3. I should have recreated sort of what the buckets are, but basically bucket 1 is fee for service. 2 are those CMMI, risk-based, non-risk-based. Sorry, 2 is sort of value-based payment for incentives, right? So I'm paying for performance, those kinds of things, sorry. And then 3 and 4 are those that are either, upside and downside based on a fee for service architecture, or they're truly population-based, which is the category 4. So I plotted data, I missed a year, I don't have 2019 in here, but if you look at the trend, so what I find incredibly interesting is that the fee for service percentage is really not changing that much, right? 43% in 2016, and as of last year, we're only at 39%. What is changing, so here's the big shift. For those payer providers that were in some kind of, pay for performance, that's where the shift is really happening, right? So now we're down at 20% and we're moving into 41% in those category 3s and 4s. So as I like to say, the movement is happening, but it's still incredibly glacial. And, part of those challenges go back to those first, are we aligned? Are we communicating? Do we have a governance structure that allows us to happen? Are we internally aligned as organizations to actually being able to do this work? So I think that we still have barriers to overcome, and Wedi is focused on data sharing. And as I noted, that's a big barrier in all of this. So if we go to the next slide. So another survey, HFMA, Healthcare Financial Management Association. So they interviewed a series of CFO executives across healthcare systems. And they asked them, so what are the most important capabilities that you as an organization think are going to need to be successful in your journey to value-based care? And if you look at the top, it's interoperability is extremely important in over 72, 73%. That's pretty significant, right? But all these other things we know about, making sure that there's eligibility verification. And I link that to that whole attribution conversation we've heard multiple times during the day. Post-discharge follow-up to me, that's the care management, are we care coordinating and managing the patient and member as one, as opposed to, the payer manages my care in one direction and the provider manages me in another. And I will tell you, I'm sure many of you who had to intervene and be the, proxy for one of your loved ones. So when my mother was sick, I was basically her healthcare proxy. And I would get calls from the, her payer constantly asking me about this program and that program. And then the provider would call me and I'm like, could you guys just talk to each other, please? I'm just sort of, I'm not your translator, right? And if you can't get this right, then how do you think you're going to deliver good care and pay for good care, for my mother? So I think we all can relate to that in some way or another. Real-time data access, if you just think about our previous discussion and some of the work we're doing in Da Vinci, not just having the data, but having the data where you need it, when you need it is incredibly important. So I think all of these highlight that, again, there are these core competencies that we're all starting, that we're developing, that we're continuing on this journey, that, a lot of us have just, we're rolling up our sleeves every day trying to do this. In order for us to get to that ultimate end game, right? And shift that, percentage, that 40% still hanging out there in fee for service and start nudging that in a different direction. And then if you go to my last slide.
And before you jump in here, Linda,
sure.
we heard Dr. Groves bring this up earlier. If the payers are going directly to the members and cutting the providers out, we really do need to work together. So, we're all getting to the same end goal. There's nobody, trying to do anything wrong. But, the new plan, the new partner health system payer model is what's going to get us closer. So
absolutely, that sort of close-knit linkage. So the last thing I just want to close with before I turn it over to my colleagues is I have been doing a series of workshops with HFMA for the last, I think I've done it for 3 years running. And we always ask the same questions every year. So but we had a new twist in 2020, and that had to do with COVID. But the question was, what are your barriers? And I would have a panel of both providers and payers sitting around, and we'd ask the same series of questions year after year. And, for people interested, you can go look at those on HFMA's website for those of you who are members. If not, I think there are some on our website. But interestingly enough, this was the first year, COVID. I said, all right, so I want to understand, did COVID change your thinking around moving to value-based care? And if so, why? Because I had heard from some of my payer customers and prospects that actually they'd been trying to sort of get a couple of their large health networks to enter into value-based contracts with them before COVID, and they just couldn't get them to move. It just wasn't happening. But all of a sudden, especially in that first, 8 months to a year of COVID, before we were all vaccinated and could actually go back and feel safe going into a building, and when we resumed some of the, regular surgical procedures, they were cash poor. So our payers were cash rich, right? Because they're not paying out for those surgeries, right? The hip replacement, the knee or whatever, that's not happening. So the payers are sitting on cash, and the health systems are just struggling, right? Because they're paying for these sick COVID patients, but they're not getting that, except there were a handful that were in, some kind of value-based care arrangement, whether they were getting a PMPM or they were getting their budget. And yeah, there had to be adjustments made because the quality measures were off, because you weren't seeing the same set of patients and you weren't seeing in the same context. It's really hard to get a full physical when you're doing a virtual visit. But the point being that there was this sort of shift in rethinking. And what our health plan partners were saying is that we actually saw some of them sort of shake loose and say, all right, we're thinking about it. Let's talk about it. So here are just quotes that I think were helpful or interesting from one of those conversations. So health plan CEO, there are new opportunities to engage a lot of people in the discussion around value and a desire for change, especially when it comes to addressing disparities in care and social determinants of health. Really important, right? You can't do that under the harness of fee-for-service. It's really hard because I think, again, during your conversation, Michael, we were talking about the fact that you got to take care of a population, right? And a population includes everybody, and not everybody's healthy and not everybody has access to care, but somehow you have to create that equity. The second thing, VP of a large health system, I expect that the pandemic will lead to increased adoption of value-based payment models. And then the last one, CFO of a large academic medical center, asked, what would good data sharing between a payer and provider look like? And they said, if we had a system-wide, community-wide, interoperable systems, I think that would go a long way towards eliminating gaps in knowledge and gaps in care. And so I'm just going to close with that. But again, interesting perspectives that you get from the industry when you actually ask the questions.
Yes, thank you. Thank you, Linda. And Michael, if you could just stay on that slide. Would love to, at Edifecs, we work with lots of payer clients, provider clients, state Medicaid agencies. So I'd like to concur that, we were in discussions with many plans, and they were really focused on Cat 2, Cat 3, right? Not, still, as Dr. Grove says, still on a fee-for-service foundation, but moving towards value-based care. It wasn't beyond June of 2020 when our clients were reaching out to us and saying, yeah, we really need to move faster to, Cat 4, partial cap, full cap, can you guys handle that? And we were like, oh, of course. So we definitely saw that. And just another story, a state Medicaid client of ours, I spoke about this at many times at the World Healthcare Congress, Rise Health. They don't like to be outed. So I won't say their name or identify the state, but they had deployed a quality framework before the pandemic, in fact, in 2017. And they were collecting, ironically, specific statistics from their nursing facilities, their long-term services and support facilities on respiratory care, severe enhanced respiratory care. So not only were they collecting metrics for quality, they were collecting facility metrics. So how many beds do you have? How many beds are open? Do they have Wi-Fi capability? Do they have, capability to, do the massage and the suction capability? Do they have the enhanced respiratory equipment? And then also looking at the training of the staff, the number of staff, the training, what's their training levels. And what the state Medicaid agency was able to do in conjunction with the MCOs was to create a quality tiered system where these nursing facilities and long-term service and support organizations were sending in monthly data on all those statistics, not just quality, but facility, training, staffing. And when the pandemic did hit, and it hit everybody hard, right, especially in the nursing facilities, I reached out to them. I said, how are you guys doing? Do you need us to, add some quality measures or some metrics? No, we're fine. We sent out an advisory on best practices, but right now we're doing really well with the data we have. We actually know, based on the tiering system that we created years ago, what facilities are doing well, which facilities could take additional folks. Obviously, targeting the respiratory care was very fortunate. And if you look at public data on mortality in nursing facilities, you'll see that this state was in the bottom 3. So really important to get this quality. I think the pandemic, as your slide shows, Linda, has turned the page a bit, maybe pushed us a little further to the crossroads. But I do thank you, and I do thank InterSystems for sponsoring this great event. So I think we're going to move to one of my favorite companies. I say it a lot, but CAQH is the silent superhero. Hopefully, Erin, you have your cape on, because we'd love to hear a brief history of what CAQH has been doing. You mentioned 2018, a great study that was brought forward, some of the subgroups, some of the advisory boards on value-based payments. Please give us an update on what has happened, and then we'll move to Michael for what's coming up.
Sounds great. Thanks, Michael. If we could move to the next slide. For those who are not familiar with CAQH core, and I went through the participant list, I think there's a couple of you. I'm going to give you a little bit of background on our initiative. Back in the late 90s, early 2000, when HIPAA was first passed, and included requirements for standards for the administrative transactions in healthcare, what happened as organizations began to implement these standards was that there was still a decent amount of variation in how that information was being exchanged. So a provider working with multiple health plans trying to exchange, for example, an eligibility transaction, was getting different information back from different health plans, which made it very hard to automate systems, which is really the whole goal of standards. So the industry came together and created CAQH Core. We now have over 100 participating organizations representing a wide variety of stakeholder groups in the healthcare industry to develop operating rules which help support and create more uniformity in how standards are used. The initial operating rules address the eligibility transaction, including requirements for patient financial information, real-time responses, and that concept of operating rules really gained traction in healthcare. They've been used in other industries for many times. In fact, CORE was modeled after NACHA, the Financial Services Operating Rule authoring entity. And so over time, we have grown from a small voluntary initiative to being recognized by the Department of Health and Human Services as the National Operating Rule authoring entity. And operating rules are really defined as the necessary business rules and guidelines for the electronic exchange of information that are not defined by a standard or its implementation specifications. So it doesn't conflict with the standard, it builds on the standard. We see our role not only to convene industry work groups and subgroups to develop and vet operating rule requirements. We have really robust discussions amongst our participating organizations, but we also see our role to drive adoption through our certification program, through our ROI measurement efforts and pilots, as well as through industry education and outreach. We move to the next slide. I just want to highlight all of the organizations that participate with CAQH Core. It really is valuable to bring all of these perspectives to the table because you learn one thing from a stakeholder group that's having a challenge, and another stakeholder group will raise their hand and say, well, we're sending that data. And then the third stakeholder group says, well, we're not passing it through. And so having every voice at the table is really critical to the work that we do. We move to the next slide. I want to talk about some of the work that we've done in the value-based payment area. Back in, it was around 2016, 2017, our board identified that they were having a lot of the same challenges implementing value-based payment arrangements that CORE was initially founded to address with the administrative standards. So as organizations were implementing various value-based payment arrangements, they found that there were different requirements for each different contract, making data exchange very burdensome and expectations very challenging. A lot of manual effort and administrative burden being created. And the board really felt there was an opportunity to bring the industry together to streamline some of the processes related to value-based payment. So we conducted a 2-year study and ultimately identified 5 key opportunity areas where the industry could smooth the implementation of value-based payments, and published a report and ultimately developed our first set of operating rules in this space, which I'll talk about in a minute. But the barriers presented here have really persisted since the publication, and in many ways, I think they've become more complicated as value-based payment models have evolved to meet the changing needs of the population. So just to highlight the 5 areas, the first is data quality and standardization. I think we heard about this throughout the day today. The data reported and provided as part of a value-based payment model lacks uniformity and can complicate data exchange and potentially jeopardize care coordination. And the issue is persistent and affects both program management and the evolving utility of the models themselves. So for example, analytics are an increasingly important component of value-based payment program administration. And without data uniformity, participants may find it difficult to secure a platform capable of managing disparate data sources, and that limits their ability to draw actionable insights into their practice. So as these models have evolved over the last few years, data uniformity continues to be an important issue, and we're seeing this more as support increases for using value-based payment models to collect and address social determinants of health. And Mike from our team is going to talk a little bit about that in a minute. Interoperability, no surprise there that interoperability continues to be a challenge. What our study found was that technical interoperability wasn't necessarily the challenge. We know what is needed to exchange the data, but we still lack standardized approaches across the various contexts and data needs to manage a value-based payment program. And the COVID pandemic has stimulated increased attention to interoperability and automation as providers and payers have sought to eliminate wasteful activities. And also new since our study, really the concept of the need to collect and use social determinants of health data as new sites of care, and stakeholders are brought into the conversation to coordinate unmet social needs. That's another area where we are still seeing interoperability evolving. Quality measurement was, a huge issue back in 2018. I think it continues to be. We heard a lot from providers about the challenges in non-uniform measures, but also in non-uniformity in how the measures were collected and exchanged between providers and payers. And we think that remains true today based on our research. We do think that FHIR-based solutions can provide some relief, but that implementation is still in its early stages. Moving forward, there's also a growing desire to incorporate better measures of patient experience and social risk factors into quality measurements. And both of these will be key issues in the evolution of value-based payment contracts. Patient risk stratification was another issue that came up time and time again in our research. Risk models are not harmonized between value-based payment contracts, and as much as providers would love that to be the case, that's not something that's on the agenda from a health plan perspective. However, providing greater understanding of how the models are used and how you can include things like quantifying social risk are becoming increasingly important as well. Finally, and this is the topic that the core participants decided to address first, was challenges around patient attribution. So we heard time and time again, providers did not know which patients were attributed to them at the time of service, often finding out way past when they were able to influence the outcomes of care. And so I'll speak on the next slides about some of the operating rules that we had developed. But even despite this progress, the CAQH index report asked some questions this year around patient attribution, and I think we're going to release the data shortly. We still found that upwards of 40% of the providers still indicated that they are unsure of which patients are attributed to them in a given value-based care contract. So this is a persistent problem. Our vision for the work that we are doing is really to develop a common infrastructure that drives adoption of value-based payment models by reducing the administrative burden, improving information exchange, and enhancing transparency across clinical and administrative verticals. So if we move to the next slide, I am really excited about the new patient attribution operating rules that were approved a little over a year ago by the core participating organizations. There's really two rule sets. The first is a single rule we call the single patient attribution status data content rule. And that rule builds on our existing eligibility and benefit operating rules, which, as I mentioned, were some of our initial rule sets. And this rule requires that a health plan return the attribution status of a patient, whether it's yes, no, or partial, and the effective dates of that attribution within an eligibility transaction. And it provides a mechanism to do so, so that that information is being exchanged within the provider's workflow. The second set of rules we call the attributed patient roster rule set. And these rules use a version of the X12834 member reporting transaction. to standardize the minimum amount of data elements a health plan needs to return to identify a roster of patients within a given value-based payment population, including the contract names and the effective dates of that attribution. As well as the infrastructure rule that complements that, which creates standard expectations for exchange and requires health plans to send providers an updated attributed patient roster at least once per month. And that was, again, a challenge we heard that was really inconsistent across value-based payment arrangements as to when and how that information was being sent. And so these rules are available for industry for voluntary implementation today. So if you're interested, please reach out to us. We would be happy to walk you through the core certification process there. My next two slides just kind of lay out the workflow as you think through the impact these rules might have. So in kind of the previous scenario, I think we're missing a little bit of this slide, but in previous, before the operating rules, what would happen is a patient schedules appointments, the provider checks eligibility, services are rendered, and the provider at no time realizes that this patient is attributed to them. They're receiving inconsistent patient rosters. It's not at all connected to the patient's record, and then the provider doesn't meet the necessary information to fully satisfy the terms of the contract. If you go to the next slide and you think about, wow, incorporating this patient attribution information into the eligibility response so that at the time of service, the provider knows before meeting with the patient, this patient is attributed to me, as well as they're receiving these patient rosters at regular monthly intervals, then the health plan receives the information it needs, and the provider ideally receives that eligible bonus at the end of the VBP contract terms. So a lot of opportunity here as our kind of first foray into this space and to create some more consistency. But I think one of the things that concerns me most, and I know a lot of my colleagues, is that without collaboration, if we don't think about this, the environment for value-based payments is really ripe for repeating that scenario that emerged in the fee-for-service environment more than 2 decades ago. So much like the operational challenges today in value-based payments, initial adoption of those electronic transactions was slow, it was complicated, and more costly due to a lack of common rules for uniform use. So that's really kind of the mindset we're taking as we make this next step in thinking about how we can help streamline value-based payments.
Thank you, Erin. And Michael, if you could just stay on that slide, I'd just like to amplify. I mean, we're looking for the holy grail, right? We're looking for infusing value-based care contract information into an existing workflow, right? So you're not burdening. I mean, correct me if I'm wrong, there's got to be millions, maybe a billion eligibility and benefit checks going between payers and providers every day. They're using this functionality every day for the past X years. So being able to infuse the information of that this member's in a contract and other information, that payload is so valuable. And then the 834, which is an enrollment, payers today, if you're lucky, you get the attribution set at a point where you can distribute it downstream to your providers every couple of months. We've already heard multiple times during this virtual spotlight that attribution is so hard. Well, CAQH tackled that first, and using existing X12 transactions that are used every day in millions or billions, strike me down if I'm wrong with the millions, billions, but I know that's one of the biggest things, and you're not adding any additional workflow. So I just, I was so proud to be a member on that subgroup, looking forward to the next. With that, let's introduce Michael Phillips, who's gonna tell us what's next at CAQH. What are we gonna tackle next? I know we took the original 5 and you're working on expanding that. So Michael, I'll turn it over to you to bring us home.
Yeah, great. Thanks, Mike. And thanks, Erin, for the great introduction as well. If you can go to the next slide, Michael, there's so many Michaels on this call today. So as Erin laid out nicely, and as Mike just introduced, we're really building on the foundation of the report that was released in 2018. And I really want to emphasize from the jump that the 5 operational areas that Aaron just described are just as relevant today, or at least we believe are relevant today. They haven't gone away, and there's still things that need to be addressed. But we also have to be fair and address the fact that the value-based care landscape, value-based payment landscape, you'll hear me use those interchangeably throughout, has evolved in the last 4+ years. So I want to run over some of those trends and some of those emerging obstacles with you all today as we reinitiate this work and build off of that initial foundation from 2018. So there's 3 major areas, and I'll start from the top. The first is health equity by design. It's well known at this point that the pandemic laid bare inequities in our healthcare system. Access, quality, outcomes differed by race and ethnicity to an unacceptable degree. As part of this, value-based payment models have been recognized across the industry as a potential vehicle that can address these disparities as we try to identify ways to mitigate potentially harmful social determinants of health. We look forward to contributing to this important discussion. I'll circle back around on this at the end, but this may include incorporation of social risk into risk models, quality measurement that's more inclusive and meets patients and beneficiaries where they are versus designing models that are not inclusive in many ways. Second item here is program complexity and administration. In my notes here, I always write this down, but it's always true. I say, let's face it, value-based payment has never been easy. It's true, it rings true, and it always sticks in the back of my mind. But I'd argue that value-based payment models aren't supposed to be easy. But to date, model design has contributed to pricing arbitrage as well as self-selection biases. You hear about this a lot in evaluations, value-based payment models that have largely been unsuccessful to date at producing savings. But as models evolve to meet new priorities, such as the incorporation of equity, and seek to deliver finally on some of these existing promises, like cost savings, we are seeing them grow in complexity, and they've steadily grown in complexity over time. For example, value-based payment models are more reliant on the development of high-value networks. Previously, this was seen as a strategy for success. It's now a necessity for success, as participants must find a way to contain the healthcare dollar into high-value networks. Furthermore, infrastructure investments such as IT or data analytics are prerequisite to produce savings. Both of these examples, so beneficial to the participants, are complex and costly, and sometimes to the point where the potential of an incentive payment from these value-based care programs or value-based payment programs don't match the level of investment being put into it. So these are new challenges that can benefit from automation, benefit from smoothing implementation, particularly when you see the barriers that participants are having to overcome. Lastly, and this is very much an emerging issue, and I would expect this to be really picking up steam in the coming months, is value-based drug pricing. Drug prices are out of control. It's another sort of known truth of healthcare. And outcomes-based or value-based purchasing prices, where drug cost is linked to the outcomes that they produce, is seen as one potential method to drive down costs. The reason why this is emerging a little bit more aggressively in coming months is that recent regulatory relaxation is allowing manufacturers to report multiple best prices based on their value-based payment contracts. And this is seen to potentially be a catalyst for value-based payment models within the drug purchasing space, particularly among Medicaid contracts, which has lagged in the past. If this prediction comes true and we do see an acceleration in this space, you can anticipate that these contracts are going to face very similar barriers to what the more, I suppose, traditional or clinical models have faced in the past. Before moving off this slide, I just want to say it's important to recognize, and as has been a theme throughout this presentation, that each of these areas is bringing new challenges and considerations to the space, but they are interacting aggressively sometimes with the known operational areas, the 5 areas that Aaron detailed before. For instance, health equity is touching all 5 areas as we seek to update the models and create new models that consider health disparities at every level of design. I mentioned before, this could be risk adjustment, this could be quality measurement or interoperability as participants seek to network and engage with community-based organizations to address unmet social needs. Additionally, the issues outlined in program complexity rekindle discussions around interoperability and data sharing, as well as, and I think this is a very important note to add, it adds complex contracting responsibilities. It's already difficult to initiate a contract for a value-based payment program. I've heard speakers reference earlier and quite adeptly, you need to know how your payment is coming, how your quality measurement is coming. Now, as these models evolve to meet new needs, you need to know how you're collecting social determinant data. You need to know what your network is doing. You need to know how you're sharing your funds to a downstream provider who helped you achieve savings. So these are all new issues that are emerging and are going to continue complicating this space. CAQH Core is committed to continually evaluating the space and identifying industry solutions that ultimately will promote automation. And as we seek to evaluate the appropriateness or assess the appropriateness of operating rules in this space that can bring about levels of automation. Next slide, please, Mike. So I just want to close out here, spoke at a very high level of sort of what our next steps are and the like, but just want to close with some objective examples. So resting again on value-based payments, building on that foundational work, we are currently undertaking a comprehensive value-based payment environmental scan, working with our industry partners to validate the 5 original areas, as well as the new and emerging trends to find out how those are interacting with these challenges. And also anything that we might be blind to or maybe so nascent that there's not a lot of documentation on, we want to work with our industry partners to understand what's next, what's coming, what can we get out ahead of. 2 other projects. First is evaluating the intersection of healthcare claims and value-based payments. So part of a larger undertaking is evaluating our healthcare claims operating rules and finding ways that we can enhance them or create new operating rules. And value-based payments will play an integral role in this because of the complexity of an existing fee-for-service claim structure sort of being plugged in to a value-based payment model. And then lastly, and particularly relevant to value-based payments, is the impact of automating CPT2 or other quality data codes. We're cooperating with vendors and provider partners from around the industry to demonstrate the return on investment or the benefit of automating the capture and documentation of CPT2 codes, which are often used for performance measurement for just general insurance contracts or payer contracts, but as well as in value-based payment contracts. So 1 live initiative and 2 up and coming through the next couple of quarters. But we are going to remain active in this space and are constantly evaluating the market for new pilot opportunities.
Great. Thank you so much, Michael. And I'd like to take this opportunity just to invite everybody. Thank you again for staying on for a long session, but I think we had some amazing speakers, amazing content to review. So I hope it was worth it. If you are looking to possibly join any of our work groups, the Wedi Payment Models Work Group is every every 4th Tuesday of the month. Just go to the Wedi Work Group community homepage or contact Samantha Hovey via email and we'll get you signed up. Also, we have a brand new work group, the Health Equity Work Group. Linda Rowe is actually a co-chair for that, and that'll be launching soon. Linda, do you have a date of the month that's going to happen, or is that still in works?
I think the co-chairs are meeting for the first time
Okay.
tomorrow afternoon to start talking through some of the logistics, but we're very excited and we hope a lot of folks will want to join that work group.
I signed up. I think I was one of the first. I reached out to Sam right away. So we're going to work collaboratively. I think there's going to be a lot of cross work between the 2 work groups, as we've heard today in the sessions. There's a lot of crossover for payment models and health equity and social determinants of health. Michael, do you have any wrap up here for, it looks like we got a slide for future events?
Thank you, Michael. Yes, upcoming events in the month of August, August 2nd and 3rd, Wedi Summer Forum, our first in-person event in over 2 years, August 2nd and 3rd at the American Dental Association in Chicago, Illinois. Day 1, focusing on the No Surprises Act. Day 2, solving key data exchange business issues. So excited to be in Chicago at the start of next month. And then later on in August, the virtual spotlight on telehealth. That will be on Zoom on August 17th. We have so far speakers from Cherokee Nation, the American Telemedicine Association, Zoom, and a lot more. So hopefully visit wedi.org to register. And to close out, I'd like to hand it off to our Vice President of Federal Affairs, Robert Tennant.
And Michael, I just wanted to say a few words before we close what was a very successful event. First, I wanted to thank all of our wonderful speakers. They brought an amazing level of knowledge to the group. A special thanks to Michael Patwell for being a phenomenal moderator throughout the day and for taking the reins of the payment models work group for Wedi. We're very excited about that. Systems, and a very special thank you to Linda Rowe for lending her expertise today as well. And programs can't occur without the wonderful work of the Wedi staff. I wanted to recognize Samantha, Bill, and a very special thank you, Michael McNutt, for making things go so smoothly. And thanks to all of you for attending today's events. I hope you got a lot of it. And as Michael said, we have an event pretty much every month. So I would encourage you to check the calendar and become part of the family. So with that, I will close the event. And again, thank you all and have a great day.
Thank you.